So good morning, everyone. Maybe I'll have the microphone on. It should be good. Okay, good morning, and I hope that everyone have a good night. Some of you actually survive, I can see. It's great to see you here. So let's open the second day of the symposium. And now a few housekeeping. At the end of the sessions, we would like to have a group photo of the faculty as well as actually the delegate that actually attend today. So hopefully you'll stay for the photo. Some of you might have to leave a bit early for the flight, so it's best that we have the photo straight after this session. Thank you. So I'll hand over now to Marcus, chairing the first session. Great, thank Marcus. Look, this is very provocative, and actually this is why I got Marcus here to share his perspective on the talk. But I thought it deserves a talk to pay tribute to innovations that I think have changed the field of interventional endoscopic ultrasound. In fact, the inventor of this device received the highest endoscopy award at the Crystal dinner this year. And I think it's good to go through the journey that he went through and why he has come up with this and how it's progressed over the last, I think, nearly 20 years. So I started my training with Ken back in 2007 and 8, and you can see that I was still a baby there, and Ken basically looked the same. And this is at the old unit, and you can see that it's very small and very crowded, but this is a very good group of nurse and doctor. So Ken have perform a number of gallbladder drainage for medical unfit at the time. And I remember at the time we used the tubular fully covered metal stents to do this. And technically it's successful at the time, and we fixed this with the pigtail stent. But probably about 30% or more of these patients come back with trouble. They have bowel leak, and they have abdominal pain, and some have stent migration. So we sort of think how can we anchor the stents better or prevent this complications of leakage and even perforation. So we said maybe we need something that keep the wall together. So he employ a team of engineers. And the lead engineers also have a surname of Nguyen, Kung Nguyen. And they able to make a cold luminal stents that's come together as you deploy. And we spent quite a few Saturday and Sunday to do pigs. And this has been published by Ken, I think in the 2009, I think. So it starts with a cold stent, as you can see there, and this requires puncture with needle, wire, dilatation of the tract, and then put the stents in. And again, some of the dilatation sometimes can lead to bowel leak and cause complications. So I think he make adjustments to the delivery system. And I think the cautery tip to allow a smooth insertion and immediate deployment have make a huge difference. And you can see actually yesterday that actually William actually demonstrated very nicely that you puncture, you deploy. Literally, you can actually drain a pseudocyst or any form of actually collection within 5 minutes. So it's actually have actually improved actually the way that we do this. So overall, the way that's actually had been transformed until now, prevent perforation, prevent the leak, and actually improve the efficiency. And actually from this, you can see that now there's variations of the stent, but all actually are trying actually to oppose the two lumen and prevent actually the complications. So we have actually a number of device technology as actually outlined here. So I think the concept start with gallbladder drainage, and then actually we see this indication for pseudocyst or actually wall of necrosis actually drainage, biliary drainage, gastroenterostomy, and actually more recently actually we go for the EDGE procedure, gastrostomy in altered anatomy or gastric bypass. So most of these data actually been presented actually by faculties actually from yesterday. I'm just going through very quickly. So we know actually the most frequent indication that we do for drainage using the exos is actually pancreatitis fluid-related collection. In the past, actually surgery and interventional radiology, and over the last actually 15 years or so, I think endoscopy have become actually the first line. And there's actually been a number of studies that compare actually EUS versus surgical drainage. And overall, the clinical success actually is similar in this randomized trial, but certainly actually the EUS approach actually have less adverse event, and that's why it becomes actually the first line. The other major problem is when you have wall of necrosis, you have to remove those necrosis. And our surgeons always said, previous plastic stents that you go in, you can't really remove those necrosis, and they can get infected, and patient can get problem. But now, because of the ability to do necrosectomy, we can also endeavor into that area, and certainly endoscopically, necrosectomically help. Now, there's a number of ways that you can do endoscope necrosectomy. You can do by dilating the tract and put the scope in, or you can use the exo stents or the luminal stents as a conduit to allow your safe insertions of the gastroscope for the necrosectomy. In the past, even though we can dilate the tract to 15 insert the endoscope, I can see in some case you can separate the wall and cause perforations if you're not careful. So I think the stent-assisted necrosectomy have made a difference and improve the safety of this process. We're all aware the potential risk of bleeding from the lamb, but again, this had been reduced or minimized by inserting a double pigtail stent to prevent the irritation of the inner tube. So this randomized trial published in Lancet have shown that compared with the surgical step-up, the endoscopic step-up approach by EUS have very similar primary endpoint, but certainly we have a lower rate of pancreatic fistula and less hospital stay. And again, when they follow this up after 7 years, the benefits still observed, and predominantly with less pancreatico-cutaneous fistula and less intervention. So we can move to malignant biliary obstruction. Now you can argue that we often don't do a lot of surgery for biliary obstruction. You either go for a surgery percutaneous, but sometimes you might consider biliary bypass as a surgical thing. So I include this very short sections on how the stents have make an impact here. So not all biliary obstruction can actually be dealt with by ERCP, particularly those that have invade the duodenum and prevent you actually to reach to the side. And one very easy approach is actually if you can insert the stent actually at the duodenal cap, and initially we do this with a tubular stent, which actually again encounter the same problem as actually gallbladder drainage. But again, with actually the appropriate luminal opposing stent, particularly the smaller one, the 8 millimeter, you can actually do this actually very nicely and prevent actually that complication. So certainly it is actually a technique that you can actually do if ERCP is not possible, and actually your units actually don't do a lot of PTC. The outcome is actually very good with these techniques. Technical success actually over 90%, as well as clinical success. Please actually aware that actually adverse event is about 10 to 12%. But again, I have to say actually with the LAM, it's less. You need actually to make sure that your duct size is actually at least 12 to 15. Actually toward the 15 is actually the ideal size. We even actually have a randomized trial that's actually performed by the AEG group. Actually, Sundip was actually part actually of this study, led by Anthony Teo. This study compare EUS-guided CBS with actually ERCP with fully covered stent for malignant distal biliary obstruction. Now, in short, actually the outcome very similar between the two groups. The only difference is the technical success. The EUS approach actually have very high success rate, 96% compared to ERCP, which is 76%. Some can argue actually why actually ERCP is so low there. And the procedure time, as we know, because actually it's EUS actually driven, it's actually much shorter, so 10 minutes comparatively to 25 minutes. So you can argue that actually EUS-guided drainage with the LAM can actually replace actually our routine ERCP, and I know some of you have a feel that actually we should all actually go for EUS drainage rather than muck around with ERCP. The other benefits actually of avoiding ERCP is actually preventing the pancreatitis complication of ERCP, and also actually avoid actually the tumor ingrowth that we do see through distal biliary stenting. So where's next? So I think actually that concept and actually the safety actually able to actually to hold the wall led to the concept of we call endoscopic gastric bypass gastroenterostomy. And I think exactly this is actually a big development in the field, and of course connecting actually the excluded stomach to allow us actually to intervene is a big development. So we all know about gastric outlet obstruction. This is actually common with actually pancreatic cancer, and particularly those that have advanced cancer. Now, patients with chemotherapy survive a lot longer now, and local disease infiltration actually is a major problem, and we have to actually deal with these patients actually more commonly. So there's two ways that we can manage actually this in the past, actually surgical bypass, if the patient actually does have actually a reasonably long survival, or enterically metal stent. Now, surgical bypass actually does lead to prolonged eyeless, and sometimes actually it's the eyeless that actually impair the patient quality of life and prevent further treatment. Whereas actually with the enteric stent, they're very safe, very easily to be inserted, but they require actually a lot of re-intervention due to tumor ingrowth. So if we actually have a way to actually to do the bypass similar to the surgical techniques, but much less invasive and durable, that will be actually ideally techniques in these patients. So this is what I tried to show yesterday, but unfortunately the case yesterday is not appropriate actually for EUSGJ. So what you do is you put a nasal-biliary tube into the DJ or proximal jejunum. You insufflate the loop of bowel with saline or water, and actually that will allow you to see the loop under ultrasound. You insert basically the stent, deploying it. I routinely dilate the tract to allow things to go through quickly, but that is variable. And I think we are increasingly doing this. It's much less invasive to the patients. Recovery is quick. So up to last year, we have a lot of report, prospective and retrospective. In short, technical success is very high, as was clinical success. Adverse event, again, is around 10%. There's been study compared with duodenal stenting. Again, the clinical success in this setting is positive or better with EUSGJ, with less stent dysfunction. The adverse events even lower in EUSGJ in this particular study. And when you have a study that compare all three techniques, again, EUSGJ come on top with the most benefit in the hospital stay, and it's also have a lowest rate of recurrence obstruction. The AEG group, again, with Sandeep and Anthony, they have compare this technique with duodenal stenting in a randomized fashion. Again, it showed no differences in the patency, but you need to have more re-interventions with the duodenal stent. The outcomes in both groups up to 6 months are no differences. It was no differences in adverse event. However, the quality of life as well as the obstructions is better with the EUSGJ. Last year, we have 2 randomized trials that compare the endoscopic versus surgical gastroenterostomy, one from US and one from Europe. The one from US Florida group have a slightly lower sample size, and the primary outcome is the gastric symptom score, and the need for any further interventions. And in short, EUS approach is better, much less re-intervention compared to surgery. It's 5% versus 33%. Quality of life is better. Procedure times is much shorter, 25 minutes versus 110, and hospital stays is 3 versus 9. So it's very positive, and this is confirmed and supported by a larger randomized trial from Europe, nearly 100 patients, 50 in each group, and confirmed that the EUS approach have much shorter time to solid than the surgical approach. Purely, I think, is we negate the problem of post-surgical ileus. And certainly all of the other events are very similar, include the adverse event. Let's move on to another area where we're connecting parts, and we all know that gastric bypass always pose problem for us when we have biliary complications or disease. We often in the past have to use balloon assisted, or for our surgical colleagues, they can do laparoscopic assisted ERCP. Both have their weaknesses, including complication rate and time consuming. With the balloon assisted arthroscopy, we all know it's technically a lot of time, and even when we try to do it, the rate of success is probably 50-50. We need to get there, and then we cannulate with actually a device that's not designed actually to cannulate. So the concept of trying to actually connect the excluded stomach, similar to the concept of laparoscopic assisted ERCP, but this is done by endoscopy and lack of surgery, is you can connect and actually put your scope through and you can actually do normal ERCP. Overall, the technical success is actually very high, and I think all of us actually do the EDGE procedure here, and actually it's quite a safe procedure. So this is actually just a video to show how we do it. We have a typical sort of appearance of the excluded stomach there. I call it the Christmas tree appearance. And once you puncture with a 19 gauge, you blow it up with liquid or water, and you can actually put a bit of contrast to confirm that actually you are in the stomach. And once actually you blow it big enough into a created collection, you can actually deploy your lamp, and that's how actually you create your connection. Again, I actually tend to actually dilate the tract and actually put the normal gastroscope and make sure that actually it is in place. And once actually you have that, you can actually dilate up to 15. I tend not actually to do the procedure, the ERCP, on the same day unless the patient's septic. But if actually they do, I often actually have to fix the stent, because actually I think a lot of report actually showing that if you do actually on the same day, the chance actually you would displace the stent acutely is high, and if you do, it's actually generally a perforations, and it's not a good outcome. So majority of the time, if the patient's not too bad, you do this, you bring the patient back in a week or so, allow the tract actually to form, and actually improve actually the safety actually of your procedure. So again, actually a lot of small report on actually this technique. Technical success and clinical success is actually over 90%. As I actually mentioned here, up to 4% of perforation, and usually this is often related to actually trying to do ERCP immediately, and actually the scope can actually be big. So dislodgement is actually a major problem. We actually published this study showing this is actually a very good rescue procedure. So we look at about, I think, 20 plus actually patients who have failed balloon enteroscopy through wide gastric bypass. We convert to EDGE, and actually we have actually success clinical outcome for all patients with 0 complications actually in this cohort. Another area I think is very useful with the lamp is the afferent loop syndrome. We see this actually in patients who have post-Whipple surgery and recurrent disease causing a blow-up of the limb and related obstruction. In the past, our surgeon might have to go back and do a surgery, but now we can do this decompression with the lamp. I don't need to go through the data for EUS guided gallbladder drainage. This has been supported by the AGA, and this is for high-risk surgical patient with acute cholecystitis, or for patients who we had the percutaneous drainage and need to be internalized. And most of the time, this is for malignant patients. There's been study to compare the whole 3 techniques, and again, the lamps for gallbladder have high success rate in both technical and clinical success. Now, for Marcus raising what's the potential of the lamp for gallbladder drainage. I know colleagues in China use these techniques to deal with gallstones. They put the lamps in, go in, remove the stone, and clearing out, and then actually they remove actually the lamb to seal off the fistula tract. But again, actually, the patient will have recurrent stone, and you might have to do this actually a couple of times. So I'm not sure whether actually that will be taking off actually that well. But again, gallbladder drainage actually had been compared with actually PTC, and it is actually better than PTC. So I think actually there's enough data, but all of these data support actually the use of these techniques, and the use of lamb come from expert center. So I think actually to disseminate this into a general gastroenterology practice, I think we will require a lot of training. You can see here that actually there is a learning curve. For example, the EUSGJ. Usually you need actually between 30 to 40 cases actually to make you sufficient and actually safe actually to do so. So I think actually in the next 5 years or so, I think as a society, we need to actually focus on how we can actually promote training and actually improve actually the safety of these. So in conclusion, I think actually the concept of lumen opposing stent have revolutionized actually the field of therapeutic EUS, and I think actually the focus now is actually not on actually collecting data, but actually on how we can actually train and improve actually the safety of these procedures in general gastroenterology. So thank you for your attention.
Thank you, Nem. I'm not completely out of work yet from the sounds of it, but we're getting there. I think we're going to add another talk, at the end of this session. So unless there is a burning question for Nem now, we might keep going and then keep the questions for the end.
Thanks, Nem. I think we'll go to the next talk. It's my pleasure to welcome Professor Sandeep Laktakia from AEG Hyderabad. Sandeep is well known to us, and he was here yesterday in the live endoscopy. So he's going to be talking to us about intratumoral therapy for pancreatic cancer, pancreatic tumor and cancer current status. Thank you, Sandeep.
Thank you, Krish. Good morning, everybody. We had a wonderful day yesterday. I'm sure most of you are now recharged. So the topic for the second talk, I'll try to be a little briefer, is intratumoral therapy for pancreatic tumor and cancer. A little high-end stuff, sorry. But I'll try to make it simple. So there are several types of pancreatic tumors, and the standard of care is surgery if possible in most of them. But that's not possible always. If the tumor is advanced, we need to palliate them with other options. Or if the tumor is very benign, the justification of doing a major resective surgery is also debatable. Having said that, there are several ways to skin the cat. Fine needle injection therapy inside the tumor using either alcohol or chemotherapeutic agent, and some immunotherapy which includes dendritic cell vaccines, gene therapy, and nanomedicine. These are all experimental and have not kind of reached any clinical levels. Probe-based ablation, which I would be touching upon, including radiofrequency ablation, is the most important method of palliating these tumors. Other methods to burn or ablate this tumor include microwave, cryoablation, and pulsed electric field ablation. So I'll be limiting my talk mainly to radiofrequency ablation. Switching gears, pancreatic tumors can be both solid and cystic. In solid tumors, we have adenocarcinoma. Only less than 20% are resectable at the time of diagnosis. Pancreatic neuroendocrine tumors, which are often incidental findings, often asymptomatic, and can be potentially cancerous in some cases. Then there are other tumors like pseudopapillary neoplasms and so on and so forth. So management of pancreatic tumor options is conventionally surgery, but that's in few eligible cases with significant morbidity. and there are limited options in patients who are high risk for surgery. Chemotherapy, which is the other spectrum to treat patients who have advanced disease, is not so effective. All the new drugs are coming up and they're finding favor, but still in a small proportion of patients. In neuroendocrine tumors, if you see, the chemotherapeutic agents are only meant to stabilize the tumor. So they don't shrink back, they just stay there, and if they stay like that for years, oncologists feel very happy. I don't know whether that's the way to look at it. If you don't do anything also, they look like that. So whether to do or not to do is also a question. Other options of pancreatic tumor management is radiation and tumor ablation now. So it's tumor ablation which I'll be fixing on. So things which have been tried more aggressively is RFA, ethanol, and a little bit of microwave and photodynamic therapy. So limiting myself to EUS guided RFA, the mechanism of action is that when you puncture this device into the tumor and put on the generator, it gives a very high frequency alternating current, and this gives a local heat which causes coagulative necrosis of the tumor and burns. Quite counterintuitively, it also needs cooling effect so that the needle gives heat outside, but inside it's kept cold by a countercooling mechanisms. There are several devices have been tried. The USRA from StarMed Korea is the most preferred device and widely used globally now. The other device like Habib US RFA probe and hybrid therm from Irby have been withdrawn. This is how an USRA probe looks like. It has a needle which has a sheath, and then the uncovered part or the uninsulated part is the active electrode. So this is the active electrode, this is the insulated sheath, and this is the sheath of the whole needle. And this is then connected to a generator and also to a water pump which goes through the hollow of the needle to give it cooling effect. So EUS RFA has been mainly used for neuroendocrine tumors, and I believe RFA will become the treatment of choice in small pancreatic neuroendocrine tumor. It's still not in the guidelines, but it's making waves, and hopefully next Adelaide meeting you may be having in the guidelines the way the things are moving. So PNET is actually increasing in frequency. If you look at this paper, all the tumors put together, this is PNET which is going up, and the way it's progressing, it's going to have waves, and number of patients would actually increase tremendously. So whether all the patients should go for surgery would then be questioned again, and why not try a non-surgical, minimally invasive endoscopic ablative option which is quite safe and effective. In fact, in our unit, our surgeons have started referring all neuroendocrine tumors to us because they don't want to have complications of a small tumor which is asymptomatic and have complications, which is well accepted. In fact, in the guidelines, up to 50% of complications is accepted, which includes leaks and pancreatitis and so on and so forth. But if you can make this less than 10%, which is in most RFA by US, then it's a fair assessment of using this technology. And that's why I keep pushing it forward. I think NAM also is one of the strong proponents of using this for at least neuroendocrine tumors. So surgery is currently the gold standard for tumors which are more than 2 centimeters in size. If they're on surface, you enucleate. If they're in the body of the pancreas, you resect. If it's a tail, it's a distal pancreatectomy along with spleen. If it's in the head, you do Whipple's. So the morbidity of this is delayed gastric emptying seen in 5 to 18%, pancreatic fistula in 14 to 58%, bleeding in 1 to 7%, and then endocrine exocrine insufficiency in so many. Plus, in-hospital mortality is also accepted up to 6%. I think this is going too far to kill a tumor which is not causing any harm to you. And plus, patients who are high risk for surgery are not considered. So non-surgical options currently is if the tumor is less than 1 centimeter, just observe and allow it to grow, and once it reaches that 2 centimeter, then you cut it. That logic doesn't apply. And if the patient has comorbidity, then what do you do them? Chemotherapy doesn't make any difference. Targeted therapy is only considered in patients who have metastatic disease. So in this group, there's a lot of anxiety among the patient and the doctors and the whole family, the environment of this. So RFA is a very good option in this group of patients. NET is a mild disease, we know, and RFA is minimally invasive and potentially a definitive method of therapy. We don't require a sword-like surgery to kill a small ant. It's very easy to do. Anybody who does FNA or FNB can actually start doing it. We just have to know a little bit knowledge of generator and the device. So let me show some cartoons of this. Imagine this is a pancreas. The green is a pancreatic duct with a stent inside. And this is the RFA probe which has gone inside. The white part is actually the part which burns. The rest everything is insulated all the way. So you start from the deepest most part, burn that, then pull it back, and you've done at least 1/2 of the tumor, and then you can make another pass and burn the rest of the tumor. So it's quite effective. Let me show us a video of this. This was a patient who actually has insulinoma. You can see the tumor is very nicely visible. You can see a pancreatic duct very close by, and these are very vascular lesions, unlike yesterday when we discussed in the live case. And this tumor measures about 1 centimeter in size. So here is the needle which goes in, less like an FNE needle. You can actually see it quite well. Stay within the boundary of tumor. That's the only golden dictum that we need. Press the paddle and you see the burn happening. This is actual burn happening. Only thing you have to avoid is not to go through the pancreatic duct. So one must be careful not to injure that, because that carries a risk of pancreatitis, which can have its own complications. And there we saw that another area is still left behind, so we can burn it. We can also do a contrast enhanced use. We saw it very beautifully demonstrated yesterday. To see whichever area is still more vascular, you can actually ablate that area. Now with SMI, we can actually need not do that, but that's one option which was there before SMI came into picture. So using all this logic and push, we published our small experience almost 10 years back for patients who had insulinoma, who are non-operative candidates. The surgeons were not willing to touch them, and they were symptomatic with their hypoglycemia. So we did RFA in these patients, and they had a dramatic relief. Within first 24 hours, their sugar comes back to normal. Not only that, their symptoms of hypoglycemia reduces, and the sugar remains normal for at least 1 year in this follow-up study, and there were no procedural adverse events. So this made us a little more bold, and several other people then started using this and expanding the horizon to pure non-functional neuroendocrine tumor. So in this study, which was from Italy, 61 patients of neuroendocrine tumor, the overall efficacy was 96%, and there was no difference in patients who had functional and non-functional. Functional you follow with hormones and glucose. Non-functional you only follow with imaging, cross-sectional imaging, and see if the tumor has actually gone away or reduced substantially in size. And this study also predicted that tumors which are small in size, less than 18 millimeters or so, have the best response. Larger the tumor, maybe you require more sessions at different time period. Marc Barthet and his group from France then did a prospective study on both neuroendocrine tumors and pancreatic cystic neoplasms. They had 30 patients and 17 cystic neoplasm, 12 neuroendocrine tumors, and they found that among the neuroendocrine tumors, 12 of them resolved. In 12 patients, there were 14 tumors, so sometimes they can have MEN1 syndrome, which can have more than one tumor. 12 resolved and 3 had delayed response. So there is also a delayed benefit. You don't only burn at the same time, but if you do a CT scan a few months later, you will see actually the shrinking happens much later. Same goes for cystic neoplasm, where 11 out of 17 completely resolved and 1 had a partial resolution. Complications, yes, 10% is average accepted complications even in experts. We then collaborated our experience with a larger international group and published in CGH in 23 of insulinoma, comparing surgery versus US RFA. And in this propensity scored study, we found that the adverse event rate in surgery is about 61% versus 18% in neuroendocrine tumor or insulinoma with RFA, US RFA. The severe adverse events were negligible in US RFA compared to 15% in surgery. The relapse rate is there in US RFA, but we always have an option of coming back again and do it few months, maybe a few years down the line if the tumor comes back. And the hospital stay is hardly 2 to 3 days compared to surgery, which is 10 days or even more. The follow-up has, in this study, was about 2 years versus 3 years for the surgical arm. Now, changing gears to pancreatic cancer, which is actually the main killer, and does RFA help here? The last word is still not been said, but it is still found to be safe. This is our work with the Korean colleagues, and we found that we can do it safely and feasible. This is how a tumor looks like being burnt. They are larger in size, and you can be more aggressive in burning, but try never to come out of the boundary, because then you can cause complications. So if this is a tumor with a metal stent inside, after some time, 2 months later, there's hardly any tumor and see necrosis inside. So that's how the response looks. But since it is a systemic disease, sometimes you may find metastasis elsewhere, although the primary tumor may not be visible objectively. Italian group again also showed a similar experience of safety and efficacy of, not safety, but I would say safety and no adverse events using RFA in pancreatic cancer. So it's feasible and safe. What is more interesting is publications in last 2 years in this area. This is Carlos Robles Medranda from Ecuador, and he and his group has published in GI endoscopy 2 years back, and they found that patients who had US RFA had a better survival compared to those who had a standard of care. Not only locally advanced, but even metastatic disease had a survival benefit in this study. I'll just skip a few things here. And they found that at 6 months, 11 of the 26 patients were alive. Of this 11, 10 were locally advanced and 1 were metastatic. Normally, these patients do not have that much survival. The ECOG score improved in 11, and even the median tumor size reduced in both group, metastatic and non-metastatic. This is a very important, a small study, but I think worth a look from Neerav Tosani, my friend from Houston, Texas. They used RFA in patients who were operable, who had chemotherapy, and then they underwent surgical resection, which is what we all want. So in this small group of 3 patients, resectable tumor, they received chemotherapy and intermittent RFA, 2 or 3 sessions between the chemotherapies, and all of them underwent Whipples without any adverse event. So it did not affect the surgery, which is what the surgeons often think, whether you will affect the field of their operative area. Pradham Chai from Thailand now published very recently, last year, of a 1-year survival of unresectable pancreatic cancer, size 4 centimeter or smaller, treated with EUS, with or without EUS RFA. They found that 2 arms, one group had RFA and standard of care, other had no RFA, and they found the survival was beneficial by at least 6 months or more in patients who received RFA. So let me show an example of a patient who had a Whipple's procedure actually earlier for his pancreatic head cancer, came back with reoccurrence at the anastomotic site. This is a PJ stricture, PJ area, pancreatic jejunostomy area where the tumor is. This is the jejunal limb, you can see, this is a tumor, and no options were available. So we had an MDT, and everybody decided, why not try RFA along with other chemotherapeutic agents. So we did RFA in this patient. Let me show a video of this. That's the tumorous area. The duct is dilated, pancreatic duct is dilated upstream to the mass. And this patient's main symptom was pain. Although we knew that this was a palliative attempt, his pain actually reduced after this. We didn't do any celiac plexus neurolysis or anything extra apart from the RFA and the chemotherapy, the second line therapy which was offered by the oncologist. Let me just take it forward. This is how we keep burning and go in different direction. But try not to hit any vessel because bleeding is a major complication. Looking at complications of pancreatitis is one of them. So we use indomethacin suppository just like we use for ERCP. We prevent pancreatitis also by using a prophylactic PD stent if the duct is very close to the margin of the tumor. And we anticipate that that's going to get burnt. GI bleed and perforations are other complications. So this is a patient who had pancreatitis. He had a stent inside. You can see this is a tumor. And that's the stent which is almost going through the tumor. So there was no way that we could have burnt without putting a stent. And still, he had minor pancreatitis. We were less aggressive in such kind of patients who have duct very close to them. In spite of taking precautions, he had mild pancreatitis, but it's still worth it. Bleeding, this was one patient who had an RFA. This was a live workshop case, and I was embarrassed by doing it, but nevertheless, it's a learning curve. So this is a tumor there. This is a portal vein. It's long position from the duodenum. You go deep in, and you see the burn is, while it's burning, the bleed is actually going inside the portal vein. So bleeding into vessel is not a problem. So it's spontaneously stopped after some time, and so that's one thing we want to show. This was another patient who had a significant bleed. This was a lady who literally pushed me to do an RFA and didn't want a surgery. It was a large tumor, not a good candidate for RFA. Anything less than 2 is okay. This was 2.5 centimeters plus. So we kept aggressively burning, and during that time we saw some hematoma developing in the gastric wall. And then we turned to the endoscopy view and we saw a lot of blood in the lumen as well. We immediately took, so you see this is the blood which is kind of accumulating there. It's actively bleeding. And we didn't waste any time and took the patient directly for angiography and embolization. So it was a gastroduodenal artery which got injured. I would like to conclude here by saying that EUS RF of pancreatic lesions is precise, minimally invasive, and safe. One caution is that interposing pancreatic duct, major vessels, and GI wall have to be avoided in the burn. Neuroendocrine tumor, both functional and non-functional, can easily be ablated by EUS RFA. It's safe, effective, sustained, and it's poised to become a standard of care. Pancreatic cancer, there is a technical success, clinical success, we don't know. Can it be an add-on therapy, as some of the people have shown recently, to this current standard of care? So we can join hands and give our best. More studies are needed for longer follow-up, like for any new technology to develop. Thank you very much for your kind attention. I invite you to WCOG meeting in Delhi this year. This is a major meeting. Andrew's dad is the president of WCOG, and he will be coming there. Thank you.
Thanks, Sandeep. It was a very good run through. I think we got a few minutes which we can take some questions. So let me start off. What is the mechanism of action, do you think? Is it, I can't believe that it's just mechanical there, just shrinking it, or do you think it also has any immunological mechanisms there? Prolongation of survival and things should have an impact on the tumor biology.
Great question, Krish. I had a few slides on that. I kept it out so to save time, and if it came up. So yes, burn is there, but also immunological action is there. We expose some of the tumors in pancreatic cancers, and that's why sometimes the metastatic disease actually starts disappearing. So the antigens get exposed, the natural killer cells and the not natural immunity of the humans then come into picture, and then gets attracted to these new antigens and affect them. Once this happens, the same immunogenic cells from the human body then kill the tumor cells elsewhere. This has been shown in animal experiments, in mice experiments, where the tumors are put on the rat body, and once you give ablation on one side, not only that goes away, but the other side, which has not been touched, also reduces. This is called as abscopal effect, where RFA probably helps.
I think this is a very interesting area to work on, especially also with the intratumoral oncocyte and so on.
Yes.
Which is an exciting area which is going on, and to watch it. I think
So just to share further that Nirav Susani's group, when they published, they had a few patients who had metastatic disease, and their mets all disappeared. So one of the patients has 10 years survival, which is unknown in pancreatic cancer. So it's worth looking at, and they said that keep doing again and again, which keeps exposing. It's like taking the vaccine again and again.
Yeah.
Has that same effect been seen with other modalities like DDT, laser, microwave? Does that happen?
So microwave is still very new. It's still not. PDT is only tried for cholangiocarcinomas. I don't know whether that works well there, but it's worth exploring with other technologies as well.
Yeah, I think certainly we have and sort of heading to that area of immune induced. So with OncoSeal or phospho-32, not only we think that it will affect the immune response, but it can alter the microenvironment of the tumor. So we saw an increase in vascularity that's actually able to deliver more chemotherapy to the area. And then the ASCO effect, we're going to study that with the immunotherapy agent as well. So hopefully in the next few years. But this is actually a very growing area, local therapy.
There's several trials now going world over on randomized controlled trials of comparing RCT of RFA versus no RFA and plus other standard of care. We are part of some of those. So hopefully next couple of years we should have more answers to this. Yes, Linda.
Sajid, thank you. That was an excellent talk. I've had a few patients where I really wanted to do EUS RFA, and the one that comes to mind is a 95-year-old, lots of comorbidities, but very symptomatic from a small insulinoma. And I've had trouble getting an EUS RFA probe. So my question is, would you consider alcohol ablation or an alternative in this setting? And then my other question is for all the Australians in the room, does anyone have access to an EUS RFA probe? And my third question is, you said be aware of vessels and the pancreatic duct. How do you adjust for it? Do you not ablate as close to it? Do you decrease the wattage? How do you adjust?
All great questions. So the first question first is whether can we use alcohol. Yes, there are some publications on using alcohol versus RFA, mainly from the Korean group, and they found it to be quite effective. The only drawback with alcohol is it's a universal solvent, and it can easily penetrate out of the capsule of the tumor and go into the normal parenchyma and cause pancreatitis. So that's the only risk, and you have to inject very, very small amount, tiny amounts. You see a clouding and then stop there. Mike Levy has shown in his first publication that how it looks like. So 0.2 ml has to be injected in small doses into the tumor proper. You can use a 22 gauge needle or a 25 gauge needle because it goes very easily. So head-to-head trials are not there, but I believe RFA is safer than alcohol, but if nothing is available, you can still use alcohol, but stay within the center of the tumor and let it penetrate out without going outside the boundary. Nam and other colleagues can answer which is available, which device, and I was talking to Andrew yesterday, and he was saying that one French RFA probe from you can.
So I did a fantastic talk, and I'm amazed you didn't mention cysts as well. Big publication showing lack of progression in those who'd had RFA for their cystic lesions, for those with worrisome and high-risk stigmata. We've done a lot in the last year. We've actually struggled to get it, and I don't know if Device wants to update us on exactly where they are with their probes. We've had the StarMed and the Taiwan here, the StarMed and the Habib. I was previously using the Habib. In regards to the vessels, no, I never had any problems. There was a heat sink, so I don't know about the efficacy. The duct is a real problem, so I've had one really bad pancreatitis with a CVD stricture, but no, the vessels for me weren't ever a problem. I think it's a heat sink, isn't it? So I think
it's a heat sink effect, yes. But if you're burning the tumor, it burns.
Yeah.
Heat will dissipate very quickly, like we have learned from the liver, where they have more luxurious volume of tissue available. They can keep burning and nothing happens to the normal liver. Even if you burn, liver has a huge reserve capacity. Pancreas does not give that luxury to us.
But so I think we should be singing this one from the rooftops. I mean, they've just had this huge media push about the RAS drugs, and obviously this is not randomised, but it's it's a similar efficacy in locally advanced than the RAS drugs, which are getting huge amounts of publicity at the moment. So I think it's time.
So for Linda, coming to your last question of the what settings do you change when these vital structures are next door? So we reduce the wattage, yes, and reduce the time of burn, but never go through pancreatic duct. It's a disaster. We don't want complications to happen before this technology, because the first few publications which came, actually they had severe pancreatitis, and this technology went into disrepute, and it was actually used by surgeons intraoperatively. There's one very recent paper in JAMA from Netherlands group, and they've said it doesn't work. But there are several caveats to that paper. We've sent a letter to editor along with Nirav that it was done by radiologist in a patient who's getting operated intraoperatively. So that makes no sense. You give this technology to endoscopists, they will do a marvelous job, and not to people who are not doing it.
Just one more thing. What's your threshold for stenting the pancreatic duct in this situation?
So yes, if the duct is less than 2 millimeters away, put a stent in. And I tried to put a stent one day before, not at the time, because I don't know whether my stent is causing pancreatitis or RFA is causing pancreatitis. So I stayed for a day and then do it.
And if the lesion is distal, you need to stent fast.
Absolutely. We have to go beyond the tumor.
I think we'll move on to the
Thank you.
Andy is waiting forever. Thank you.
Thank you. Thank you, Sandy. It gives me pleasure introducing our next guest speaker, Professor Andrew Metz. He's the head of endoscopy at Royal Melbourne Hospital, and his main interest is in pancreatology and running a dedicated pancreatic clinic at the Royal Melbourne Hospital. He's also the counsel and treasurer of Australasian Pancreatic Club as well. He'll give us his wisdom on pancreatic cancer screening.
Fantastic. Thank you, William, and the organising team for allowing me to speak. And I'm really thrilled to be able to talk about where we've been up to with this study, really with the help of everyone in this room, in really only a short amount of time, less than 12 months. So, why do this? Sorry. Failed the intelligence test there, but look, back onto the talk. So, why do this? We know that pancreatic cancer has increasing global incidence, and it's more than doubled over the past 2 decades, and particularly what we've seen is an increase in young adults. Now, there are worrying stats you see in the newspapers here, and I think it's really important still to remember this is a relative risk increase, so it's still very, very rare if you're less than the age of 45, but we are seeing it. And so what we know is it is increasing rapidly in incidence, and unlike other tumours that have made big strides in regards to screening, early detection and therapies, and therefore big improvements in mortality. Whilst there has been an improvement, a mild improvement in mortality over the last decades, it's really not to the degree that other cancers have seen. So it's really time for the pancreas to have its time in the sun. And why is screening considered in pancreatic cancer? And the problem with pancreatic cancer is it's really hard to diagnose. We know that patients, and this is from retrospective reviews in the UK, patients have seen their GPs between 3 and 6 times with symptoms prior to the onset of diagnosis, with 25% of pancreatic cancers diagnosed 6 months after the onset of symptoms. And again, this is not a criticism of GPs. The symptoms are often vague and non-specific GI-type symptoms, and 20% of what GPs see are vague GI and non-specific symptoms. So to try and find that one single pancreatic cancer is very, very difficult for them. And this is the reason why the vast majority, almost 80%, present either locally advanced or metastatic, and why the 5-year survival rates are really only a dismal 13%. But what we do know is the earlier we find these lesions, the better. So if we can find a lesion that's localised, the 5-year survival is 44%. But more importantly, if we can find a lesion at stage 1A, so less than a centimetre in size, or even at the high-grade lesion, which is in the pancreatic cyst, that the 5-year survival gets up towards 84 to 95%. So what we know is, yes, absolutely, there is data to say the earlier that we find these lesions, the better. But should we be screening everyone? And the answer is absolutely no. So it's still not a common cancer, only 4,000 to 5,000 diagnoses a year in the Australian population. And we know that therefore the general population lifetime risk is really only about 1.5%. So really it's not clinically feasible, or it's not cost effective to screen the entire population. And certainly, when everyone knows, trying to get access to the screening modalities at the moment would rapidly overwhelm the system. So cost effective data from the states, and again that can't be extrapolated completely easily to the Australian healthcare system, but generally says that screening is only worthwhile when the baseline risk is substantially higher, so likely at least a relative risk of 5 to 10 times baseline. We also know that the vast majority of pancreatic cancer is not genetic. So probably around 10 to 15% has absolutely an inheritable risk. But again, 85 to 90% there is no really inherited risk, and there's more likely to be sporadic features around those. So the earlier we find things, the better, but we shouldn't really be screening everyone. So who is at risk? And really we break these down into two groups. So the first is those with the high-risk syndromes, predominantly the colon cancer syndromes and the breast cancer syndrome. So Pearce-Jaeger's, the BRCA, BRCA1 a little bit higher than BRCA2, and the PALB2 mutations, as well as the colon cancer syndromes like Pearce-Jaeger's and Lynch. We also know that the genetic pancreatitis groups, so the mainly one being that of the PRSS1, have an incredibly high relative risk. What about those with a strong family history? And the first thing to say is if you have one single affected family member, your relative risk is slightly higher, but not hugely higher than if you have no affected family members. And I think that's really important to reassure patients. I'm sure you are, as we are, getting overwhelmed with people who say, I have a grandparent at the age of 80 with pancreatic cancer, I'm worried myself. And I think we're in a good position to be able to say, look, your risk is slightly higher than the average population, but not so high that the likelihood is you're still not going to get pancreatic cancer. So it's a really good opportunity in that consultation to talk about risk factors, ensure no smoking. If there's diabetes, ensure that there is a really good control of diabetes, and obviously a healthy weight and good diet and exercise are really, again, important to stress. These patients, the new diagnosis of diabetes or change in unstable diabetes is a different kettle of fish, which we're looking at setting up a study for as well, because 50% of patients with a new diagnosis of pancreatic cancer had a new diagnosis of diabetes within the preceding 3 years, and I think obviously these patients are a big group we'll be looking at, but I think at this stage, outside of any clinical trials, it's reassurance and a good opportunity to discuss risk factors. But again, for rare cancer, once you start to get to 2, 3 or even 4 affected family members, the relative risk comes up dramatically. And we have a good number of patients with 3 or 4 family members, and their relative risk getting up to 30 or 40. And again, these are really patients that we want to target. So we know the earlier we find things, the better, and we know who's at risk. So we put these two things together and think, this is probably a good thing to do. So do we have evidence? And the answer is not yet in Australia, but there is evidence from overseas. And what did they find in the Combined CAPS consortia in Australia, in America, with almost 2,000 patients? They found that actually a good percentage were at stage 1 at diagnosis. More than 90% actually got to surgery rather than less than 20%. And the 5-year survival was 74% rather than 13%. And when you look at a median survival rate, which on average when we wait for symptoms is about 1.5 years outside of any screening program, the median overall survival was getting up towards 10 years. So the data is suggestive that it is the right thing to do. So the PROCEED study as well, which we were a part of, again found that a really high proportion actually had pancreatic abnormalities. Now, look, a good proportion of those are neuroendocrine tumours and cystic lesions, and there are we creating more work for ourselves? But it does suggest that even in these high-risk groups, cysts and neuroendocrine tumours come at a much higher rate, and that's certainly what we're finding ourselves. But clearly we've got evidence gaps. So we know that there is earlier diagnosis is a better outcome, higher resection rates and improved survival. But we also know there are huge amounts of data that we really don't know. There's cancers arriving in interval scans, and we've had some of those particularly in our cystic patients actually. We don't really know what the optimal surveillance intervals should be. We know that it should be at something less than 3 years. If you look at the American cohort data, biochemical and imaging changes started up to 3 years before the time of diagnosis, so things are really happening in quite a short period. We clearly would want better biomarkers, and issues around cost effectiveness remain uncertain, and certainly that's something we're doing alongside this with our plan to present to government about this next year. And as we've discovered, implementation at national scale in a country like Australia has its challenges. I had brown hair before this whole thing started. So, is there justification for a national program? And the answer is absolutely. So I know a lot of people in this room were part of the National Pancreatic Cancer Roadmap with the goal of reducing risk and finding pancreatic cancer early. And we know that in Australia, despite it being the third biggest cancer killer and predicted to be the second biggest cancer killer in Australia by 2030, there is still no government-funded program that we have for anything pancreatic cancer screening related. So even though the roadmaps are currently prioritising early screening and surveillance as their biggest overall goal, we really don't have evidence to support a national approach. And again, the outcome of the roadmap was that we do need a national approach here to talk about feasibility, to talk about equity, and particularly cost effectiveness for a country as big as Australia. So Cancer Australia has released national pancreatic cancer screening guidelines for primary care practitioners, and really the outline being that it should occur in centres with pancreatic expertise and in centres with multidisciplinary review. It should only be in those with high risk, again relative risks of 5 to 10 times upper limit of normal, so strong family history, or those with the pathogenic variants, and that MRI and EUS are the preferred surveillance modalities. And I'll talk about the fact that we're keeping this very open, but again, EUS has probably a little bit better data in regards to cystic lesions, and MRI has better data in regards to small cystic lesions, and EUS definitely has better data in regards to small solid lesions, and both of those have a better data than the CT pancreatic protocol. But again, what did Cancer Australia say? Absolutely, it should occur within research programs and registries to look at long-term clinical and cost-effectiveness data. So why is Australia difficult? And the answer is because the system that we have. So it's a combination of public and private medicine with different referral rules, different funding flows, different catchment areas. We know that access to MRI and EUS is concentrated in metropolitan areas, and certainly EUS really is very difficult to access outside of the major cities and major quaternary centres. We know that outside the major cities it's very hard for patients to access any of these investigations, and certainly need specialist involvement to access MRI and EUS at all in regards to the funding of the system. And there are certainly issues in regards to out-of-pocket fees that occur for these patients. And unfortunately, Aboriginal and Torres Strait Islander people who have actually the highest rates of pancreatic cancer and much more likely to die from pancreatic cancer because of their access to care, these are the ones that we have the most difficulty in regards to the equity of access in Australia. They are the ones who are located in the regions most far away from where the screening modalities are taking place. So we needed a coordinated approach, and what we've therefore suggested is that we need a national prospective cohort to look at feasibility and outcomes. We need to assess Australian data, which is significantly different, as we have discovered, from the European and American healthcare systems, to support cost effectiveness and equitable access, and therefore to look at Australian specific guidelines. And clearly, in regards to getting efficacy data, we want to ensure that our inclusion criteria completely marry up with those internationally, because for a cancer with the incidence levels that like pancreatic cancer does, we want to be able to generate robust data, so be able to have access to really large numbers here. So what is the APPRISE program, the Australian Pancreatic High Risk Screening Program? So the APPRISE program is collecting data, clinical data, imaging results, blood where feasible, and again, we can talk about this later. I know it is difficult in some centres, from individuals who've been identified as being high risk for developing pancreatic cancer. With our initial aim, and I'm pleased to say this is just initial, we can talk about how it has happened, with an initial aim of more than 1,000 patients recruited over a 10-year period, with the primary objective simply of assessing the feasibility of implementing the screening protocols amongst high-risk individuals, so either familial or genetic risk. But with the secondary objective, obviously, of determining the prevalence and stage of PDAC and precursor lesions that are detected during a screening program, to identify factors associated with that risk to see if we can better target screening, and to determine the effect of pancreatic screening on quality of life. Pancreatic worry, which we have discovered obviously is really huge in these families. We clearly want to align ourselves internationally, and we've just chosen to align ourselves with the PROCEED program. Diane Symposium helped us launch last year at WCOG IAP meeting in Melbourne, and really the team here have got 40 centres throughout the Middle East, Europe and America. And so I'm about to head over to present our first data with Hallie at the end of the year, which we're very excited to do, as are they. And they're really excited as to what we're doing as well. And as Diane said, we don't have the numbers or potentially the financial backing that America and Europe has, but what we have is a bunch of doctors who actually get on well. And so we're the first people who are able to do this at the national level. So people are, despite our small size, I think we're punching above our weight, and international groups are looking to what we are able to achieve here. And I think it's a credit to all of us as a group that we actually like each other and happy to collaborate. So, and we're happy to send these slides around, but what is the eligibility? And the bottom line is patients can contact and doctors can contact and get a risk assessment anyway. There's online and email and phone risk assessments. But essentially the two groups that we discussed. So the familial cancer groups, those with 2, 3 or more affected family members, and those with the pathogenic variants, so the colon and breast cancer variants. As well as the PRSS1s. And we do now have funding for PRSS1 and other genetic testing if you guys are unable to access it. It's again, don't record this, it's out of a Victorian grant, but we will look at the idea of telehealth and trying to get it to people in other states as well. So what happens? Look, this was our initial idea last year, but 1,000 patients. Looking at yearly screening by EUS or MRI, and again we've kept it completely open, predominantly for equity of access issues. In a country like Australia, we know that there are huge numbers of patients in regional or remote that have really very little access, or timely or cost-effective access to endoscopic ultrasound. We're doing data collection, so family and medical history, quality of life, and obviously the findings on the outcome. And look, blood collection we've kept as optional. Certainly it's very helpful, both from a genetic as well as a markers perspective, and I'll briefly talk about the markers that we're setting up. But obviously if there's absolutely no ability to get centrifuges and -80 freezers, and I do understand in busy lists that it is a problem. My anaesthetist whinge every EUS case I do. About having to take off, even though they barely have to do anything, we have such good staff, but anyway, they still whinge. So I do understand that this may be a limitation in many of the centres around the country. So if it's normal, again, repeat it 1 year, and obviously abnormal as per standard of care through the MDMs, and that's clearly the crucial part of having access to MDMs for detected solid neuroendocrine or cystic lesions, which we would follow as per international guidelines, which are nicely summarised by Sandeep for neuroendocrine. And the research really here is very important. So it's a centralised database with outcomes, incidence, stage, resection and survival adherence, impact on screening on quality of life, health economics, and we're actually expanding this to look at the impact on the PBS, were it to be brought in, the MBS, were it to be brought in. So we're looking at, we really don't even know what the numbers are in Australia of those who do have these family histories or genetic incidents. So the next step is we're working with epidemiologists to try and look at the impact on healthcare budgets, which we will present to the government next year in Canberra. But looking at the feasibility, particularly with the public and private healthcare split. I think blood is being taken for genetics, but which is part of the PROCEED program, but I think it's also really important that we have blood available for biomarkers, and we have worked with a number of companies, some of which we think have gone to the media and market too early without robust data behind them. And certainly we're working with things like BCAL and other oncology groups around the country who do believe they have good markers. But again, this is the sort of, if we are able to set this up at the national level, this will be absolutely invaluable for biomarker testing and implementation in guidelines. And again, with the final goal of evidence of formalised government screening program and contribution to global screening guidelines. So what's the progress? And I think we have to thank most of the people in this room, actually, who make up a really good proportion of the team. I know that Linda's here. We've obviously got Nam. We've actually got probably a third of the people who are part of this, which is really useful for us. So thank you to everyone in the room. Obviously the glaring problem here, as you can see, is in the Northern Territory. We don't yet have any screening centres in the Northern Territory. We haven't given up on this. We're meeting a interested gastroenterologist who's based out of Darwin to try and see what options we have, and we've also made connections with a number of Indigenous groups, Indigenous sort of healthcare groups, and advocacy groups. It's difficult, you know. Obviously, it's really important to present yourself as someone who's committed and not just fly in, fly out. No, we have just received a grant from the Hospital for Indigenous Health to see if we can work out a way of getting better into Northern WA and the Northern Territory. We've had great support from Olympus, who have suggested their fly in, fly out model. And maybe the EUSs in this room, we could all take it in turns to do a week each in Darwin. And Olympus has looked at the ideas of with their new system where they can send sterilised and processed scopes into the city for a week. But look, this is something we'll look at options really of what is the most effective and cost effective, and keep talking with our colleagues to ensure that we're not missing out on this really important group who are the most at risk. But again, thank you to everyone on this group. We couldn't do any of this sort of stuff without Chris as well. He's a big contributor to the program. So what have we managed to do since we set up a year ago? And the bottom line is that the results have been overwhelming. So we said we were going to do 1,000. We're about to hit it already, and we've been going for less than a year. So really, it was clear that the interest was from families and patients was out there, and clearly we don't want to stop at 1,000 now because we're still getting huge amounts of interest. We know this is taking place overseas. We don't think it's reasonable to start denying people access to this program, so we're already underway with more funding creation, and the plan at the moment is a seamless transition past 1,000. But as you can see, there has really just been an extraordinary interest and extraordinary enrolment. So again, all I can do is thank everyone in this room for their unbelievable commitment to this program. And again, probably just because we started a bit earlier, but Victoria is ahead, but every state apart from Northern Territory is on there. And again, as I said, that's a glaring omission that we're looking at options to try and treat. So what have we, when we look at who's actually been enrolled, and again, the majority are the familial groups, with about 30% being those pathogenic variants, and smaller numbers, as you would expect, of the PRSS1s and the Pearce-Jaeger groups. But again, really focused on the pathogenic variants. That's predominantly BRCA1 and BRCA2, again, as we would expect. And when we look at what's on our websites already, and what is the early feedback from in terms of quality of life, and the bottom line is they love it. These are patients who have watched close family members die generally quickly, generally without a great experience, and they have the same worry, particularly when they've seen multiple family members go through this. They have the same worry, even though we do talk about relative risk and not absolute risk, they have the same worry that it's an inevitable problem for themselves. So the feedback has just been really fantastic from patients and their families. Things like for someone with 2 family members of pancreatic cancer and understanding statistics, it weighs on your mind, particularly as a parent, and that the screening alleviates some of that anxiety. These people are really committed and certainly try not to miss any screening opportunities that they have available to them. So what do we need to do over the next year? Well, clearly we have built a big screening cohort with numbers that we weren't expecting to happen so quickly. We've really got overwhelming good collaboration from colleagues around the country, but clearly we need to expand to more sites, particularly in the remote and regional area, and we are going to look at making an effort to get out to these sites and see what we can do to help to be able to set it up. We clearly want to continue to enrol more participants. We're not going to stop at all. We will look at funding options, and we've got more gala balls coming up to achieve that. Clearly the biggest glaring aspect, as I described, is that in the Indigenous or the Aboriginal and Torres Strait Islander communities who we know are most at risk, and we don't even understand their genetics at all. So advertisement, as I always seem to do these days, but obviously you can refer your patients through the email, and there's a quick eligibility survey, and then formally enrolled. It is a national registry, but it's all done through our centre, but then emailed to the closest, the most appropriate screening centre for wherever the patients and their families are located. We will also have a great team to do that. And there's an online PanCalendars also set up, and we've been doing a lot of media around it recently. Set up an online eligibility checklist. So again, that may try and alleviate some of the pressures that you might be getting in regards to your referrals. So in summary, we do believe early detection is the best way to improve survival outcomes in those with a higher relative risk. The main benefit really is early detection, and either a stage 1A or precancerous lesion. And the main thing here is that we need to generate national evidence to look at the scalability, the clinical outcomes and the cost effectiveness, and really it relies on collaboration with people in the room and our international partners. Very quickly, 3 minutes, because we were discussing this last night at dinner, but the Australian Pancreatic Cyst Registry. We know now that we had a fantastic talk yesterday about pancreatic cysts. We're being hit with a tsunami of these lesions, and which will only get worse as the resolution of cross-sectional imaging continues to improve, and with the majority of these unable to be discharged because of their indolent nature but potential malignant history. And really we are going to hit problems with patient worries and capacity constraints within our healthcare system as to how best to manage this. And because of this, the International Association of Pancreatology have really said that their highest priority right now is to look at the national history and better management, exclusion and inclusion of what to do with these lesions long term. Essentially, we need the Barrett's revolution, where we can either have markers and better diagnostics or better treatments, and ideally be able to discharge the majority of these patients. But we just don't have the data. And if you actually look at most of the guidelines, and there are now 4 different guidelines. The Kyoto ones were mentioned yesterday, the new American, the AGA, are coming out this year. And they're actually not based on huge amounts of data. So I think still remains a glaring gap in that area. So I won't go through it all. It was beautifully presented yesterday. But what we do know, therefore, is that there are huge differences in what's actually happening on the ground: surveillance intervals, image modalities, and referral pathways. Clinical documentation is consistent. Use of international guidelines is inconsistent. And we really don't know the true incidence in the Australian population at the moment. So therefore, we've decided a national registry is essential for capturing structured, consistent data on IPM incidence in biology and how these cysts are best managed across Australia. So the Australian Pancreatic Cyst Registry is been set up. It's been going in Victoria for a while, and we're looking forward to expanding to the rest of the states over the next year or two. Obviously, we're waiting for people to get a prize set up. I know that people are a bit overwhelmed with the amount of work to be done, but we're obviously very happy to come and assist wherever we can. And look, it's a really nice online registry. The first one takes a little bit longer while we get patient details, but after that, it's actually really quick. And we've looked at AI, the ability of AI to populate this from records, which we've managed to say does work, but we've got issues around government, so we can't quite go there at the moment. So we're in the hundreds at the moment. We want to get to 10,000, and again, with the offer to be able to ideally help public hospital systems to keep these people out of clinics, and ideally have clinical triggers associated with this. So we'd love everyone to be involved. There's an NMA for both of these, so we're very easy to add new PIs on with the ethics application. Our team has really be able to be very helpful to help coordinate the myriad governance issues that each hospital does seem to have, and looking at research collaboration agreements and databases and training. There's payments, so a prize, obviously we pay per patient, higher in the enrolment, and a little bit less for the annual follow-up. And in terms of cysts, obviously the numbers are much bigger, so we're going to look at the idea of one-off payments annually, and ideally to be able to help fellows or research assistants in your department to be able to do this sort of stuff. And our team is absolutely fantastic, as anyone who's met them will know. And I think really I'm just the figurehead. This is a huge amount of work with a huge number of people. I think we really have to, in the back corner, I'm going to embarrass them, but Ash and Helena, if you stand up here, this wouldn't have happened without these guys. They're absolutely tenacious. They know how to deal with governance departments, which none of us in the room certainly do. And please go and introduce yourself. They're an invaluable resource, and no one can steal them from me. We have multiple people to thank. We've obviously the Dressati Pancreatic Centre, our founder Ellie, who's just hit 6 years since his diagnosis, and he's still as driven as ever to fund these sorts of projects. Pankind has been hugely supportive on this. Screening and early detection is a big part of what they do. Proceed Consortia are fantastic international collaborators. We have steering committees and working groups, and obviously everyone in this room who's been a big part of how something like this, which is a lot of work, but something like this has been able to get off the ground. So particular thanks to Ash and Helena in the back of the room. Thank you to everyone in this room, and thank you very much for listening.
Thank you, Andrew, for your initiative and the excellent pancreatic screening program. I think we're starting to run out of time, so we may have to go to the next talk unless there's any burning questions.
Well, let me welcome back Frank Violet. He's a professor of gastroenterology at the University of Waikato in Hamilton, and a gastroenterologist at the hospital there, and the clinical lead for endoscopy. He's going to speak to us about ampullary neoplasm endoscopic assessment and management. Thank you, Frank.
All right, thank you, and great session so far, and I've enjoyed some of the takeaway messages from that. And we all saw the challenging case yesterday, so it's a good opportunity to go over some of the data and processes we should follow. So ampullary adenomas are really uncommon in the general population. We all know it's more common in patients with FAP, and they do present two sort of disease entities, and some of the things we do should be done slightly differently. So in FAP patients, adenomas are found in a high percentage of patients if you follow them long enough, and adenomatous change can be detected even in macroscopically normal ampullas. The risk factors, obviously FAP itself and male gender in conjunction, but also increased risk in the sporadic population with prior cholecystectomy, PPI use. There's an increase in risk in diabetes and those with gallstones and some lipid abnormalities. And basically there's something going on in the microenvironment with exposure to bile and a reduction in the microbiome and those areas that drive some of the abnormal mucosal behaviour. There are some protective factors, not that we are advocating general use of aspirin for this, for example, but there do seem to be some associations. So for those patients with FAP, it's important to see that the annual incidence of progression is quite slow, so you have to follow these patients carefully. And in the study over 80 years, only a third of them developed significant progression. That means 2/3 didn't. And ampullary cancer is actually quite uncommon, so only 1.4%. So surveillance in these groups is very reasonable, it's particularly in those patients whose adenomas are less than 10 millimetres. However, the risk with advanced duodenal polyposis, once they've developed multiple polyps, they should be referred and followed that way. For this reason, there are guidelines of what we should do with surveillance, and if you use the Spiegelman's criteria, you can see that you accumulate points, and that sort of determines your rate of endoscopy, and it shortens the interval. So we do need to follow these patients, but it doesn't necessarily mean we need to remove every ampullary adenoma we see. For sporadic adenomas, there's no real guideline because they are quite uncommon. Management is primarily resection-based. Post-resection surveillance is required, and in general we follow them up at 3, 6 and 12 months during the first year, and we'll show you some of the data. Recurrence rate is in about a third of patients, and more than half of that is early, and the other half is late, and therefore the surveillance does need to be prolonged. Risk factors for recurrence is obviously if you have a positive margin, just like with any other polyp, or piecemeal resection. Endoscopic retreatment, however, is still very successful, so even if you do get recurrence or residual, further endoscopic treatment is recommended. So what do we do with the sporadic ones? How do we approach them? So pre-procedure, we need to assess these properly, not just what you see endoscopically. So if there are any concerning features, cross-sectional imaging is important if you suspect any intraductal disease. Obviously, some of us do EOS at the same time, and you can see the intraductal extension. You should pause, not go ahead, and do your staging properly, go through an MDM, and make sure that you do the best for this patient, even if you think you can take the lesion off. I think there are some risks of just proceeding without proper process. So the accepted criteria for resection are those lesion size up to 4 centimetres with no evidence of intraductal growth and no signs of endoscopic malignancy. So you can assess the lesion properly, and if you have concerns, take a biopsy and pause again. The equipment is fairly standard, so as you saw yesterday, we use a duodenoscope. There are some technical issues with that in terms of which way you approach the polypectomy. Generally, you can use a braided snares or some of the newer fine wired snares that are specially designed, more hexagonal snares, for example. And the procedure's done much like another mucosal polyp that you see. It's just more expertise is required because you are cutting into the ampullary, into the bile duct and the pancreatic duct. So there are some other skills you need to have that not everybody necessarily has that does other polyp resections. So the technique, again, you aim for en bloc resection, and that's preferred when you can get the whole lesion. Advantages if you can do that because it's shorter, less watery, unlike yesterday, with complete pathological specimen. And there's minimum risk if you do it en bloc. Piecemeal resection often is needed if the lesion is bigger than 2 centimetres or if you have visible tissue that needs further resection later on, as we did yesterday. It's advised to, once you have done the ampulectomy, to stent the pancreatic duct, and we'll leave a 5-French stent and biliary stenting or biliary sphincterotomy with or without a plastic stent to prevent delayed bleeding and stricturing. It does have adverse events. It's not quite like a polyp elsewhere. And I've deliberately left wide ranges here because range always implies expertise. The more you do and the more careful you are, your risk can be on the lower end of the scale. But certainly when you're counselling your patients beforehand, it would be fair for you to give a reasonable range of what risk they are taking for a resection. So pancreatitis, bleeding, perforation and cholangitis, although that's very rare. You also have delayed complications, so papillary stenosis, and therefore the stenting or sphincterotomy is part of your resection technique. And there is some mortality, but that is very low in these patients. The risk factors for complications are those with high-grade features. They have an increased risk of pancreatitis, bleeding, and overall complications. And in some of these patients, just pursuing a pancreatic stent placement when you can't get into the pancreas may increase your risk, so you have to, at some point, make a judgment when not to, persist with a cannulation if that becomes difficult. And as said previously, a biliary stent may be protective against bleeding. So ampulectomy is first-line treatment in patients without features of invasive malignancy, and the success rate is very high, especially if you have an R0 resection. They have quite short hospital stays, low complication rates, and good overall survival in 5 years of 92%. For those patients, just as we saw yesterday, if you have a lateral spreading component, you take care of that at the same time. And unlike in the live procedure, you should take the lateral spreading component first and isolate the ampulla, and then take the rest en bloc. It was 4 o'clock yesterday, and we're trying to get it all done in one, but that is actually not the correct sequence. You should have reversed that and taken the lateral component first, ideally. So recurrence is reasonably common, and this is the Westmead experience, and we'll give some more data on meta-analyses. So in the Westmead group, there were 215 patients and 166 that were included. And this is just to show that when you do your 3-month, your first scope, most of the recurrence or the residual is seen at that point. So you can then take care of the rest, do repeat resection, but the recurrence then becomes less frequent as you go along. And factors associated with recurrence was the lesion size, intraductal extension, and you can have a few millimetres extension and still take it off successfully, but if it's more than 1 centimetre, then that's probably not for an ampulectomy. If you have a lateral spreading component, as you would expect, there could be microscopic disease, longer procedure time, and on the reverse, if you get en bloc resection, you'll have lower recurrence rate and We didn't really talk about margin ablation, but that's what we did in the case yesterday after resecting the lateral spreading component, just like in the colon, used soft tip coagulation to coagulate any microscopic disease to prevent recurrence of that component. So as shown in the Westmead study, the overall recurrence rate is about a third, a 3-year cumulative recurrence rate about 20%, but even in the R0 resection, when you have a negative, your 3-year recurrence rate is still 11%. So even if you have R0 resection, you need to follow these patients. That's the point. Early recurrence is detected at first surveillance or within those first 12 months, but the other half, or 40%, actually occurs after 2 years. So if you get a clear ampulla at 2 years, you don't stop, you continue. So surveillance does need to continue, even if you have a clear ampulla at 2 or 3 years, whichever protocol you follow. Again, it seems intuitive that if you have a positive margin, you're going to have a higher recurrence rate if it's piecemeal or if it's a larger size polyp that you're taking off. This just brings the point home that probably surveillance needs to go on to 10 years. That obviously you need to look at the patient population, their comorbidities, and put it in. But if the patient's well, you don't let them go. That's the take-home message for that. Surveillance does need to continue long-term. Repeat treatment is possible, so if you do have recurrence, it doesn't mean that means surgery. And if it's safe to resect, you should do a further resection at that point, because the studies do demonstrate good endoscopic control after the first recurrence. If you have repeat recurrence, then the likelihood of success becomes less. You have to distinguish between residual adenoma, and I think mostly the first surveillance one is probably residual rather than recurrence. You've left something over, or you have some microscopic disease, and I would probably consider that as residual rather than recurrence. Outcomes of repeat resection, again, if you can get en bloc resections, it is better than piecemeal, and repeat endoscopic papillectomy. If you do achieve R0 resection rates, it has a very low, good outcome long-term and low morbidity still. Sometimes, though, you do need to consider surgery. So the lesions that have any features of malignancy, or if there's adenocarcinoma confirmed on the biopsy, larger adenomas, or if you have ductal invasion or failed endoscopic therapy. And these patients, surgery is the appropriate treatment. So surgery for endoscopic treatment failure, if you have more than 2 endoscopic resections, then you should start considering taking it back through an MDM, having a repeat discussion with your patients, and making a decision towards surgery. When the surgeons help us with these patients, they have 2 options. It's transduodenal surgical ampulectomy, and these are for the smaller lesions, but if there's any, it's either expertise or other features, then a formal Whipple's procedure. So just to summarize this, if you diagnose an ampullary adenoma, if those patients have smaller size or less than 2 centimeters with high-grade dysplasia, you can go for endoscopic treatment. But if you have any high-risk features, either size-wise or greater than 2 centimeters with high-grade dysplasia, really surgical option is probably the wisest course of action for these patients. So we still have a little bit of time. We'll just run some of these couple of cases. So this is a patient with an ampullary adenoma, and just lesion assessment shows you that there are really no high-risk features. Just as we tried to demonstrate yesterday, you try and nest your snare at the apex in the reverse direction, and then opening the snare very, very slowly. You sometimes lose the the vision of the top, so you then have to just bow your scope down and get right underneath the lesion, and then try and oppose the plastic sheath against the mucosa and then close it. And then look at the blanching of the lesion and making sure you have the whole lesion in itself. And as we were hoping yesterday, there's 2 or 3 little buzzers and it should be off, not a whole minute. I try and capture the polyp really quickly, because if you wait or just sit and look around, they can migrate and disappear down the duodenum. Once you have done your ampulectomy, you can then carefully assess the ampullary orifice and see if you can try and identify separate orifices to the pancreas and the bile duct. I actually like this 543 cannula from Boston. It's very tapered, and in this case I actually don't use a guide wire, I just aspirate fluid to distinguish between bile and pancreas. This actually takes a 0.21 wire, and then I haven't shown you the x-rays, but you place a pancreatic stent. Sometimes you get in the bile duct first, and I don't not do the bile duct sphincterotomy first. I actually take the flange off because I do want these stents to migrate out and fall out, so to try and prevent these patients needing a second procedure to try and remove the PD stent. This is actually a Cook mini-tome. Again, it's tapered. Again, I like the tapered component to that, and you can do a little sphincterotomy just to open the biliary sphincter carefully. And once you've got, in this small one, I didn't actually put a biliary stent, and then just using a soft tip to try and, we'll just run through a second one. The second case is similar. Again, seating the snare over the top, and then rotating down, and these snares are angled a little bit, so you actually have to close it really slowly. If you try and close them too quickly, they'll sort of snap. And in this case, again, trying to capture the polyp really quickly. I'll just go this a little bit further. And in this case, you can actually see 2 separate openings, and you can selectively cannulate those orifices. I might just go to the next one, just looking at time. Sorry, need to get to the next slide. This is one of the Westmead cases. Clarence just gave this to me, and you can just demonstrate a few differences. So again, careful examination. I actually like the freeze button to look carefully at what you're looking at the polyp. And again, they also use a braided snare, trying to seat the snare over the top and then slowly open. And the nice thing is that the technique is very similar. So even though I did some, and this one is from Westmead, it's a fairly unified technique that people are using. I'll just go forward here, because this is basically just demonstrating that treating margin ablation just the same as you would do in any other polyp. So I would actually recommend margin ablation for microscopic disease. So even if you think you have a complete resection, it would be important to try to inject initially to see if there was any residual, but there wasn't. Okay, so I think I'll just finish there, and thank you, Nam, for the invitation for the whole program. It's been excellent, and it's been a pleasure to be here. Thank you.
Thank you very much, Frank. We've got one more talk to go through. Is there an urgent question? can ask you one quickly. You have shown a recurrence rate of 11%, in RCO resections. Can you speculate why that is? Is this a field change or is it multifocal disease?
No, I think it's microscopic disease. I think there's, and that's why with that last case, I think margin ablation is only something that we've taken on more recently. And I think that should become standard. You should ablate the margin. We've shown in other polyp resections that if you do, you reduce the recurrence rate, and I can't see why that shouldn't be the same for an adenoma of the ampulla.
Thank you. Thanks, Frank. I would like to welcome back Nam. He will quickly finish off this talk, which was overdue yesterday, mapping of pancreatico-biliary cancer, role of ductoscopy. Nam, thank you.
Great. Thanks, Krish. So I'm going to actually give this talk very quickly. I think it's actually an important topic because we actually now encounter, and our surgeons actually does find actually this mapping process is helpful. And I think actually the technology developments in ductoscopy actually have dramatically improved, and it will be further improved and will enhance actually this area actually a lot more. So there's two actually conditions that actually will predominantly be used actually for these techniques, cholangiocarcinoma and actually IPMN, either mixed duct or main duct IPMN. So I'm just going to start with a case of a painless jaundice from a proximal cholangiocarcinoma. You can see that's actually the lesions there. On ERCP, it typically shows the stricture in the mid to proximal ducts with actually a lymph node. We did EUS evaluation, confirm actually the mass as was the node. But as you know, actually, we can actually look at the duct in great detail with the high resolution EUS, and you can actually see that's actually the duct proximal to the stricture is quite thickened. It's actually up to 2.8 millimeter in this case. So it does actually raise actually is this actually extensions actually of the tumor proximally, and this is always a question actually from our surgeons actually how far is actually the cancer actually have extended up to. So if we do go for surgery, how much actually are we actually resecting? Do they do actually intraoperative actually cholangioscopy, or actually we do preoperative cholangioscopy? So after actually MDT, we decided that we should actually have all of the information preoperatively. So you can see that's actually very nicely. This is actually a 11 French IMAX curve showing actually that malignant stricture. For mapping, actually, we go right up actually to the left and right intrahepatic ducts, actually biopsy. And you can see actually here, there is actually a protocol for cholangioscopic biopsy mapping, which include the left, right, the bifurcations, and the proximal and the distal duct. So, so what we found is actually there's no cancer in the left, right, and hilar. Again, actually the stricture is cancer, and there's no cancer actually below. So actually our surgeon actually did a local resection rather than actually have to do actually a Whipple resection. So it's actually helpful. So cholangiocarcinoma is rare but actually quite aggressive. Overall, 5-year survival is very similar to pancreatic cancer. It is more prevalent actually in countries that actually have epidemic infections with liver fluke, like the APAC region. Australia is not that much. Certainly, we do want actually to have early detections and precise mapping actually to help. But recently, we do actually have good immunotherapy actually for the cancer that actually have been shown to improve survival. Similar to pancreatic cancer, only about 20% of these cancer are resectable at the time of the diagnosis, predominantly due to late presentation, but certainly also a unique histological features of this cancer is a subclinical longitudinal spreading of the bile duct. And I think this is actually the main rationale for the cholangioscopic mapping. As you can see that up to 15% actually of cases actually they have this actually longitudinal spreading along actually the duct. And this is actually often microscopic. You can't actually see it on imaging, and you probably will have actually to see it actually endoscopically. Other challenges actually in this area is that actually it have a widespread differential. Other condition can actually mimic actually the cancer, so actually include sclerosing cholangitis, which again also actually might have foreside cancer, IgG4. There's always a limitation with the conventional imaging to actually define actually the exact location and extent of the cancer. Even when we actually will start to do endoscopic investigations like cholangioscopy, getting the tissue diagnosis is also actually quite difficult. We can actually look, and majority of the studies so far indicate that actually cholangioscopic evaluations is better or actually have a high yield than actually the biopsy. And that's actually due to actually the current technology of the biopsy forceps. That's because we only have actually up to now 1 millimeter biopsy forceps, and even actually with the best actually hand, the diagnostic rate is actually about 70 to 80%. But overall staging with tumor mapping is important. Of course, actually, if you know actually the resect margin, you can actually give a better actually surgery. So you can either downstage or actually upstage, and correct actually surgery will actually directly improve your survival and actually perioperative actually morbidity and mortality. So most of these mapping work actually come from the Japanese colleagues, and they do have this protocol that they biopsy left, right, and the hilum, and actually most often at actually the site of the stricture and actually the below, predominantly the intrapancreatic portions actually to let actually us know or our surgeon know whether they can actually avoid actually the Whipple resection. Their preliminary publications say actually this type actually of mapping give them actually sensitivity of actually detecting cancer actually in about 50% with an accuracy actually about 60%. Again, this is with the limitations actually of a small biopsy. And even with their updated cohort of nearly 100 actually patients, their outcome actually have not actually altered actually a lot. Again, sensitivity actually about 50 and accuracy is actually about 63%. They found actually the biopsy right at bifurcation to exclude any malignant involvements actually is important, and actually often actually dictate their surgical decisions and outcome. So if you just compare with ERCP alone, you expect actually the additions of cholangioscopy to assess for this longitudinal extension will improve your yield by either 10 or 20% depending on the location. So distal 10% and approximately 20% improvement that you would not actually detect by just a simple ERCP. It does actually alter the decisions in resected margin. So for cholangiocarcinoma, up to 30% of cases will have altered decisions in resection. Let's move to the IPMN. And for us, we do know this is quite a heterogeneous type of disease, patchy but widespread, with a diverse biology. We have the cyprans and the mixed duct and the man duct. Histologically, there's 4 subtypes, and they all behave slightly differently. So I think determine the accurate extensions of the disease will help our surgical colleagues in terms of surgical resection. So We only often get to help when we have mixed duct or main duct IPMN. And ductoscopy or pancreatoscopy here will allow us actually to have accurate mucosal surface examinations of the duct, and actually again guide how much the surgeon should resect. Now, most of the data support this concept come from the intraoperative pancreatoscopy. As you know, with these mixed duct or main duct, after the resected specimen, our surgeons often put the scope into the residual pancreatic duct and make sure there's no occult lesion that's been seen. This fourth study look at this again. Most is from Asia and Japanese, and they found that up to 42% they can find a occult lesion. And with these pick up, you can lead to an altered decisions in surgical resection up to 34%, as shown here. There's been many small study on this, but Dijon did the review on this in 2023, and over 500 cases. They found the pancreatoscopy itself can lead to endoscopic diagnosis up to 96%. It can detect these lesions. With the biopsy, it varies from 88 to 100%, depending on what forceps that you use. And what it found that with the cholangioscopy and the recent biopsy, it's increasing. Overall, they found that the coarse mucosa friability and tumor vessel is dictates the malignant features, and they can lead to altered surgical decision making in up to 62%. Of course, if you do pancreatoscopy, the main risk will be pancreatitis, and you expect that about 10%. Again, often you have to discuss quickly with the surgical team in a multidisciplinary setting to make sure that you do the right thing. So as I say, mapping can lead to a more extensive surgery if you found more lesions, or less extensive, and this all have an impact on outcome. So you don't want to resect and left a bit of tumor and then have bad recurrent, but at the same time, if you overcut, you will lead to exocrine and endocrine dysfunction. So probably this is the most important slide, is that once you have this condition, you raise it, you should discuss in a multidisciplinary team. And then if everyone's happy, you can go ahead with the ductoscopy for mapping, and sit back down again, discuss your ductoscopy findings, so that we can reach to anonymous decision making. Of course, I think ductoscopy is specialized, and we need to have appropriate training. Again, I'm pounding training is very hard, because their competency threshold. You can see that you probably should do about 30 plus ductoscopy before we can go solo. And because it does impact on patient outcome, training will be very important. One of the major limitations from reviewing this topic is the biopsy technology through ductoscopy so far. Now, as you know, yesterday, I think Frank did demonstrate the 11 French would have the 2 millimeter working channel. And this allow a bigger biopsy forceps, 1.6 millimeter biopsy, and their preliminary data suggests the bigger biopsy does have a better yield. But there will be ongoing improvement in the ductoscopy technology, and I know there's a new 9 French scope with a 2 millimeter biopsy channel, and this again actually will actually improve the yield. So I think this area will actually develop and actually will optimize actually in the next few years. So in conclusion, I think doctoscopy enable direct visualization and target biopsy, and this will actually improve assessment and staging of these tumor, and this indirectly will influence actually the management plan. And up to 30% of cases actually the procedure will actually alter actually the outcome, and I think it's important that actually we're aware of the limitation, but also actually aware actually the need for training in this area to optimize our patient care. Thank you for your attention.
Patients with modern chemo and immunotherapy who survive long, especially gastric cancer with stage 4 disease, and we do know the surgical gastrojects fail as well, over longer term. What about, your endoscopic gastrojectomy? Do we have long-term data on their patency, and functional, data?
I think actually there are, Sandeep might actually help me, but actually there's been reports actually of semi-long terms actually that actually cannot be up to actually 12 months actually follow-up. After 12 months, we can actually replace actually the lamp and to keep actually the patency. You can always actually revise actually the track. Because these are fully covered metal stents, so we can actually revise it as we need it.
Thank you.
Can I ask a quick question about your first talk now? So if you have a patient with acute cholecystitis who are quite sick, and you refer the patient to Marcus and say, look, this person needs a cholecystectomy or some sort of management. The patient is too sick, and he said, look, I need to do a PTC. Is there any data comparing these group of patients who receive EUS guided drainage versus PTC? Which is better?
You mean percutaneous drainage of a gallbladder? Yeah, actually there's been actually data.
Particularly, in terms of the difficulty with doing EUS-guided drainage in these type of patients with thick, gallbladder walls. Maybe can you comment on that, or even Sandeep can comment, or any of the panel?
I think actually those are the best case. Actually, that's actually you do actually EUS actually guided gallbladder drainage. There's been data compare actually both actually the percutaneous drainage and EUS, and they're actually very comparable. Or actually some actually even say actually EUS actually is safer because actually the dislogically of the tube as well.
I think they are the ideal cases to start off with when starting.
Yeah.
Milan.
Maybe for Marcus, our issue we have with the EUS gallbladder is the lack of commitment to being a surgical candidate or not. And at least our surgeons are then concerned about that stent and the fistula from the duodenum or the stomach to the gallbladder and the impact on future cholecystectomy. So a lot of people we see who probably are reasonable candidates who look pretty borderline end up going to percutaneous gallbladder drainage. It's often a surgical registrar, a fellow who doesn't want to wake their boss up in the middle of the night. I don't know if you have any thoughts about the impact of the stent on surgical approach.
Yeah, I mean, you're talking to the converted here. We've just been pulling together, the percutaneous cholecystostomy, patients over the last, 15 years. I've got a student working on that, and we always felt it's not a good procedure. Too many problems with it. It often, then preempts, a cholecystectomy later down the track, in a patient who's already quite sick, and and borderline. So I would really welcome, sort of an EUS, guiding cholecystostomy directly into the duodenum. Have no concern about, the fistula to the duodenum. That's what we do when we have, the stones do that on themselves, and we will never go back and operate. So, and this is patients which, we rather not operate on. So we really would welcome that, We obviously don't have long-term results yet, but we do have the comparisons and see that data, which is certainly better, for EUS guided drainage rather than percutaneous.
I mean,
it can be done from the stomach or from T1. Is it easier if it was done from the stomach for you guys to operate later on? Does it make a difference? Which approach is better?
I don't want to operate on any of them later on, if possible.
Because the Florida group has shown that about 12% of the patients eventually went to have surgery.
Yes.
And they raised the question of making the decision of never operable versus possibly operable.
Yes.
And an algorithm. And the whole issue here is not about doing it. It's about doing it in borderline patients who become operable later on. And the issue is what you guys have. And the approach is what we do.
Yeah. I have more options surgically afterwards if it's done from the stomach. Yeah. The duodenum is a bit more tricky to deal with, but it's both possible.
I mean, and there's data on that to support that. There's a difference between whether they're going to be surgical or not, whether you approach from the stomach versus if you approach from the duodenum. It's easier for us to approach from the duodenum in terms of doing that, but from a surgical perspective, because of the triad out there with your bile duct injury and things, it's better to go from the stomach. And Sandeep might add this, but coming back to your question, William, there are published studies, there are RCTs published on that from Anthony Teo's group, and I think you guys, Sandeep, might be involved in that too.
So some of the surgeons prefer, have no problems at operating patients who have been drained with the LAMS. And there is a opposite group also who say that they don't want any LAMS. If a patient is potentially operable candidate, it's better to have a percutaneous, and the moment his sepsis subsides, then they are taken up for surgery 2 to 4 weeks later. But having said that, if stomach is available, then that's a preferred option by most surgeons, so that the surgical field, the duodenum should be not tampered with. Don't go by duodenum into the gallbladder if the patient is potentially operable.
There's actually also a logistically issue as well. Most of these patients actually present actually at midnight, and unless actually we have a on-call EUS endoscopist, actually this is actually doesn't work. In comparatively with the IR, actually that's actually beyond call. So actually so far this concept of actually EUS drainage for acute cholecystitis actually haven't taken off. I'll keep that a miss. Yes.
One point I would add is now look at this is a benign indication. For the malignant biliary obstruction, if they have distal malignant, you have bile duct, you have intrahepatic ducts, and the gallbladder. 3 options are available to drain. There are some recent publications which say the gallbladder is equally effective. And actually maybe better. Yeah. Because surgeons used to do that earlier when in malignant biliary obstruction, just drain the gallbladder, provided the cystic duct is above the obstruction.
Yeah. Great.
Sandeep, I have one more comment and question. Is Frank here or he's left? I was chatting to Frank last night about the LAMS. What he's saying is that he puts in a double pigtail and then takes the LAMS out after a week or 2. And he says that makes it easier for the surgeons to go on and operate. Does anyone do that thing at all? He acutely drains it and then leaves double pigtail, and after a few weeks he removes the LAMS and leaves the pigtail, and then patient goes to have surgery.
This is for cirrhosis or for
for gallbladder. Gallbladder.
Yeah, if they think that patient is maybe fit for surgery.
I think that's a potential way of handling things. When you don't have a big hole there, now you make a small hole which is adhered because of the metal stent being there for about 2 weeks or so. It makes a lot of sense, I think. There's a Japanese group which is also propagating this of using an anchoring device between the gallbladder and the duodenum, and next to that they place a plastic stent. after irrigating the gallbladder, so that there is no metal stent there and that attachment is very small and can be removed at the time of surgery, lap chole.
The point is to close the fistulous tract, whatever they're
Yeah.
doing. And part of that, what he's doing is to avoid the fistulous tract, which is the surgeon's problem with the fistulous tract. Correct. So that's the primary aim.
Good. I think with that we'll close it. We're already 15 minutes late, so that you can have that. Thank you very much for all the speakers, and it was a fantastic session. Thanks, man.
Great. Thanks, Chris. Can I get everyone up here for the photo, and then we can go and have coffee? Thanks.
Testing.
All right, everyone, we might look to get this session underway, if everyone can grab their seats. So this is session 5 of our meeting, the final sort of lecture-based session today in the future in the management of pancreatico-biliary disease. So our first speaker for the session is Professor Toby Coates, talking about preserving and restoring beta cell function in chronic pancreatitis, TPIAT, or gene therapy. Professor Coates is a professor of medicine at Adelaide University and director of the kidney, pancreas and islet transplantation here at the Royal Adelaide Hospital. He has a long-term interest in islet biology and is the principal investigator in the HEPARDIS study of hereditary pancreatitis in Australia and its treatment with total pancreatectomy and islet autotransplantation.
Yeah, do you have USB? Do you have a USB with it on? No. Okay. They said I could just do it off this, and it was working before. Yeah, so let's get rid of that. Sorry. There we go. Part of it. Okay. Thanks very much, and thanks, Nam, for the invitation to come and talk today. Very much appreciated. So I'll be talking a bit about TPIAT and a little bit about gene therapy, so something perhaps a bit different to what you've been seeing before. So I'll start by acknowledging that we're here on the land of the Kaurna people of the Adelaide Plains and pay our respects to elders past, present and emerging. That's particularly important because the disease that we're going to talk mainly about, or I'll talk about, is the hereditary pancreatitis is very highly expressed in our Indigenous population, and so most of the data that you'll see when we talk about TPIAT comes from that group, and I think that's a nice mesh with the talk that you had in the previous session from Dr. Metz. These are just my disclosures, none of which are relevant for this. So I am, as indicated by the title, the principal investigator in the HEPARDIS study, which stands for Hereditary Pancreatitis and Auto-Islet Trials, Transplant Trials in Australia, and the logo, which was designed by one of our First Nations people here in Adelaide, very nicely shows the islets connected to the duct and all of the other things that are relevant for the pancreas. Not really scarred in this one, and there are all the other investigators up there. This slide I stole from John Chen. It's a very good slide because it really summarises the issue that I think Nam wanted me to talk about, which was diabetes and how diabetes causes a significant problem for patients with chronic pancreatitis. It really shows you down here on the y-axis, on the x-axis here, over time with hereditary pancreatitis, you get these symptoms very, very, very early on, and then the progression from acute pancreatitis to recurrent acute pancreatitis, and then to chronic pancreatitis. And the patients there here really all affected by the age of 20, which I think is one of the big symptoms. And I guess for the clinicians in the audience, when you speak to somebody with pancreatitis, if you ask them whether they've actually had symptoms before the age of 20, be very suspicious that there might be a gene that would be driving it. So the focus today is really talking about diabetes, but there is a significant risk of pancreatic cancer, which is highly relevant to all of us, and so understanding and recognising this condition is particularly important. So what about the development of diabetes after pancreatitis? Well, chronic pancreatitis really is associated with a substantial and time-dependent risk of diabetes. And if you want to keep a number in your mind, about 1 in 3 patients with chronic pancreatitis will end up with glucose intolerance and will develop diabetes. And there was a nice recent meta-analysis that I found when I was preparing this talk, just published this year, of over 11,000 people in 19 studies. A lot of heterogeneity in it, but what it did point out was really quite substantial risk of development of diabetes over time, and if they've had it for more than 10 years, 44% will end up with glucose intolerance, and that's highly significant, bearing in mind the complications, of course, that come from diabetes. And more importantly, 60% of them will require insulin therapy, so it's quite significant diabetes. And the other thing I thought that was a nice practical point was those pancreata that have a lot of calcification seem to be more likely to be the sort of organs going to end up giving you glucose intolerance. So the other point really to make here is that diabetes that develops after chronic pancreatitis, or the pancreatogenic type 3C diabetes, is actually a very difficult diabetes to manage. And that's because you lose the alpha cells which provide the counter-regulation through glucagon. So you get a very brittle, difficult diabetes that endocrinologists really don't like to manage, because it is really a big challenge. And add that, of course, with malabsorption, you have an inconsistent supply of the carbohydrates coming in, so it's difficult, again, to treat these patients very, very well. So if we look at the disease that I'm particularly interested in, which are the hereditary group, and in this particular case, PRSS1, this is a meta-analysis that we published this year in the journal Pancreas. And when we had a good look through, you can see paediatric-wise, you really don't get much in the way of diabetes being reported. But once you look at the adult series, here, the results are about 25%, and down the bottom is our own unpublished data that Dang Ha Wu's a PhD student in my lab. About 26% of the people that we've got will have established diabetes with chronic pancreatitis. So now's a chance to give a big plug to Professor John Chen, who's not in the audience, so I'll tell him off about that when I see him next. But preservation of islets by total pancreatectomy and islet autotransplant. And this is something that John's been a big champion of here in Adelaide, and all of the operations that we've done have had John involved in them. So he's an absolute champion from that point of view. And the reason that we can do total pancreatectomy and islet autotransplantation is that the islets, because of the fact that they have 10% of the pancreatic blood supply, are really the last bit of the pancreas that goes in chronic pancreatitis. So they're really preserved right up to the end. And this slide just makes a very nice point of that. So you can see that sea of scarring in the chronic pancreatitis over there versus the nice normal pancreas over here. And you can see with staining up with insulin in this particular case that there are significant islets preserved, despite the fact that the pancreas looks absolutely dreadful. So the total pancreatectomy is a procedure which is done predominantly for pain, and all of the operations that we do here and the operations that are done in Sydney through Gordon Thomas's group and the Westmead group all confer to the Minnesota criteria, which I put in great detail over here. Again, you don't really need to know them, but that's the criteria that we use, because it means that we basically aren't taking organs out from people that are asymptomatic. So this is predominantly an operation that is performed for pain. It's not an operation that's performed for any other indication. And it's actually extremely good at relieving the pain, and I'll show you the data that supports that, both internationally as well as nationally. So pancreas comes out, it's a very major operation, and when we do it here, the surgery starts at Women's and Children's. If we do it at the Women's and Children's at 5 o'clock in the morning to be able to do this. At the Royal Adelaide, because we're a bit slower, we usually start a little bit later for the adults. The pancreas comes out, and in this situation we fly it to Melbourne for isolation, although our own isolation facility here in Adelaide is just about ready to go, and we'll be doing all of our own stuff locally very, very shortly. The islets are isolated, and then they are flown back to Adelaide, and then we reinfuse them into the liver of the patient on the same day. So it's a big procedure, but it works extremely, extremely well, and so John's been involved in really all of them. So there have been several large studies that have looked at the outcome of TPIAT, and this is one from the United States, Melanie Balin's group, and she's really the leader from Minnesota, where this was first actually performed. And you can see here I've split this into adults and into paediatric. And you can see, obviously, coming from North America, there's a large Caucasian predominance. A lot of these patients have had recurrent acute pancreatitis, and obviously a variable incidence of the genetic ones that we talk about here. The important thing about this is that you get very, very good outcomes in terms of getting patients off narcotics, which is one of the major reasons for doing it, and dealing with their abdominal pain. And a variable rate of insulin independence. And we could talk about why that is, but I think that's got a lot to do with insurance and referral policies in the US rather than places where you've got universal health care like we do here, where we tend to get patients referred earlier and are able to tackle this condition a little bit earlier. And also I think we're probably a little bit more selective in those that we take on. So yes, insulin independence about 20%. A busy slide here. I put this up because there are a number of surgeons in the audience. There are complications with this particular procedure because it's major abdominal surgery, including all sorts of things such as requirement for ventilation, pulmonary embolism, bile leaks and all sorts of other things. But generally, it's actually a very well tolerated operation that people do very, very well with, and you'll see our data in a second. So because we're focusing on the metabolic outcomes here and the diabetes, I've just pulled all the series here that have been published around metabolic outcomes for TPIAT and modified this from Mike Rickles' paper back in 2019, review paper here. You can see a variable rate of insulin independence, and I've just highlighted here the Australian and New Zealand experience. So this is the combination of Sydney, the Westmead group, and our experience here. In 16 patients, the islet yield after transplant showing here. Hemoglobin A1C after 12 months really pretty good at 5.89%, and our insulin independence rate of about 50%, which is very impressive. Having said that, virtually 100% of the patients that we do will have positive C-peptide after TPIAT, and often with a very low dose of insulin that makes the diabetes or the glucose intolerance actually very easy to manage. So the HAPARTA project that we mentioned at the beginning is an MRFF-funded process which we were successful a few years ago, and the purpose behind this is really to use cutting-edge science to look, particularly using whole exome sequencing, at the genes that are driving this and the high prevalence of Indigenous representation, and then follow the patients for up to 5 years, looking at those who didn't get TPIAT versus those that did, and hopefully at the end of all of this produce some evidence-based guidelines about who should receive this operation, but also give us a good idea about what happens in the natural history of this disease without needing to actually have the TPIAT. My own personal bias on this is that many of the asymptomatic people that we start off with at the beginning end up becoming symptomatic and then require the procedure. But hopefully the study will show that, and we should be able to show some cost benefit. And we're about 2/3 of the way through, so watch this space. So these are the operations that have been performed so far. We've done a couple extra now, but just to point out, split into children and into adults here. The islet yield is, because children are a little bit smaller, looks smaller, about 400,000 islets per islet equivalence, which gives you about 6,500 per kilogram in the kids versus 6,000 in the adults. You can see all of the ones that we have done have had the PRSS1 gene, and we can talk about that gene and all of the problems that it causes. And this is a very heavily Indigenous influence group, and we published this, if you want to see the original paper, which was in the Medical Journal of Australia earlier this year. Length of stay is interesting. The kids stay a little bit longer than the adults, at about 20 days, and I think that reflects differences in practice between 15 and 29, whereas the adults stay between 11 and 14 days, with a median of 11 days. Again, these are the caveat dindo complications of what we've experienced in our TPIAT group, and you'll see over here, importantly, very little transfusion requirement, a few short complications such as some requiring some inotropes, but generally done very, very well. We haven't required to do a lot of splenectomies in this, which is clearly an advantage when you're dealing with kids, because you don't want to remove that source of immunity. But on to the metabolic outcomes, and you can see here, this is up to now 6 years post you can see the requirement for opiates drops dramatically, so it's a very effective procedure at getting rid of requirement for taking opiates, and good in terms of insulin independence rates, which rate very highly and probably better than what's been reported internationally, although of course the numbers are small at this point in time. Obviously, our hospital likes to know whether or not we're making any difference to ED attendances, as you'd all guess, and I love this graph because I can show this to our administrators and say, this is what it was like before and this is what it's like afterwards. So it's actually very effective at stopping kids and young adults ending up in the ED and then having to spend time in the hospital. So we like to show this one, and we've got ED presentations over here versus hospital stay. So again, details in the Medical Journal of Australia earlier this year. But there is some smart science that goes along with this, and I just want to show a little bit of it from stuff that we've been doing in the group. So when you do a total pancreatectomy, the pancreas comes out, and this particular case shoots across to, well, this is from our lab over here. There's the pancreas inside the biospherics chamber being dissected in half, and then we cannulate both halves of the pancreas and infuse the enzymes to digest. And as a part of that, as a consequence of that, we take a biopsy from the middle of the pancreas of all these patients, H&E section, so that we can look and see what it looks like. And this has been the source of some very useful work that we can do with a technology which is called spatial transcriptomics, which I'll introduce to you very quickly so you can get a feel for some of the things that we're doing. Now, these are not normal pancreases that we take out here, and you can see that quite clearly from this picture here. This is clumps of normal tissue that you can see here, surrounded by a sea of horrible fibrosis, and that horrible fibrosis is driven predominantly by the pancreatic stellate cells, which are probably the bad actors that are driving a lot of this process. So spatial transcriptomics is a very clever science where we can take H&E embedded samples, or FFPE embedded samples, and we can then run a panel of which covers the entire human transcriptome. There's 18,000 genes on these chips. They're horribly expensive. It costs $40,000 for me to buy one chip, which will do about 4 samples. The chip's expensive. The bioinformatics which goes with it is even worse. And so you generate one set of samples, and you can basically spend, as Nam would know, you can spend the next 5 years working on that one set of data and still find new things to look at. I'm not going to go into any great detail today, but really to highlight the great people in my lab, Jane Zuani, who's doing his PhD with me, and Griff Perkins, who's our postdoc, who's currently in Cambridge working on this. But essentially what this enables you to do is to look at what cells are producing what factors at a transcriptomic level, single-cell RNA-seq techniques, and then relate those pathways to what's actually happening within the diseased organ. So the nice thing about this is that we've got tissue that's taken from the pancreas at exactly the same time that we're isolating the islets. It's got this really lovely correlation between what we take out and what's actually in the pancreas at the time. And it's really no surprise, I won't go into this in great detail, but when we focus on the beta cells and we look at what's been expressed here, and there's a large number, huge amount of information that we get out of here, but essentially the beta cells are under huge stress, and the genes that regulate hormone secretion, signal release, hormone transport, AMI transport are all greatly upregulated because the beta cells that are sitting inside a chronically inflamed pancreas are extremely stressed because they're in this nasty fibrotic environment. And that's what I'll come to in the second half of the talk when we start to talk about potential gene therapy approaches. So can gene therapy, as opposed to purely removing the beta cells, actually help in this essential, or can it protect functional beta cells? And this is really an old idea, and this goes back to some really nice work that was done by Gordon Weir and Susan Bonner Weir. It was published in PNAS back in 2000. And basically, what it shows is if you take the acinar fraction, which of course is not where the beta cells are, because the beta cells are actually in the endocrine fraction, but you take the acinar fraction, you can actually differentiate functional beta cells from these ductal precursor cells that are inside the acinar fraction. And this is what Gordon and his team actually did, and I'm just really showing you the highlights here by this 8 human isolations cultured in matrigel over 3 to 5 weeks, and you can see the development of insulin-positive cells and somatostatin-positive cells within these fractions, and then the ability for this fraction to then potentially produce insulin. So this is an under-recognised source potentially where we might be able in the future to do something to generate new beta cells from the pancreas. This was taken a step further by the Baylor group, who've done exactly the same thing, and they've now taken those ductal cells and then done a gene therapy approach to deliver a number of essential growth factors, PAX6 being one of them, to induce these. This is adenoviruses, the gene construct approach here that they to generate over a period of times spheroids that are capable of expressing C-peptide, beautiful insulin granules forming in these cells, shown over here in high density, and then the ability to make C-peptide, but less than what you'd expect in a normal adult islet. So you can take these ductal cells and potentially reprogram them to do something useful. And then finally here, again in this paper in Frontiers in Transplantation just published this year, you can see these cells are capable with quite advanced and complicated series of pancreatic growth factors to be made into cells that will produce either insulin and or glucagon. So maybe in the future we will be able to reprogram the stuff that we throw away to produce functional beta cells that we could then give back in an autologous manner, and that would get over all the problems that we have in transplantation, where we have to use, obviously, immunosuppression to make these things happen and do us out of the business of islets. Allotransplantation and push us towards autotransplant, which is the way to go. And finally, I'd just like to bit of a shout out, speaking about gene therapy, to one of the Australia's best islet biologists and one of Australia's best gene therapists, and this is Professor Shane Gray, who comes from University of New South Wales here. And Shane's been interested through the islet program with us for many, many years in what happens, or the stress signals that islets have when we perform transplant procedures. And this is a very nice paper of his in Cell Transplantation back in 2013, where basically they looked at the chemokines and the inflammatory signal of islets that had been freshly isolated before we did islet transplantation for type 1 diabetes. And without going through the details, essentially islets, as we currently isolate them, come out in a very inflamed manner and express a large number of factors that promote the allo and the auto and the innate immune system. So CXCL2, for example, which promotes polymorph infiltration and therefore can damage the transplants when you actually do them. So he extended this a little bit further and had a good look to see if he could find a target that he might be able to look at. And this is in particular the target he found is this tumour necrosis factor alpha induced protein number 3, which has been his sort of life's work, really working on this. And this particular factor is under control of a very interesting protein called A20. So if you want to remember something new from today, think about A20, because A20 is a master regulator and it regulates hundreds of genes. It can down-regulate these chemokines, cytokines, adhesion molecules and co-stimulation molecules, and is a key regulator there. And so it works through the TNF1 receptor down here to inhibit gene transduction. So very effective at blocking NF-kappa B. So it's a molecular checkpoint inhibitor that can really block immune function. So by introducing A20 into the islet, you could potentially switch off the TNF signalling, which would alter that inflammatory environment. And what I've shown you all the way through here is that islets, either in chronic pancreatitis or in allotransplantation, as I just showed you, are in an inflamed situation. So it makes sense, if you could use a gene therapy approach, you'd be trying to switch off inflammation. And A20 is a very nice character for actually doing this, high tuning to do this. So Shane has shown this very nicely in a series of papers. This is in JCI Insight, that when you use a gene therapy approach, and this is the A20 into the islets, you dramatically improve the cure or survival of these cells and prolong graft survival in this manner. So it's a very nice candidate. And here functionally, in the models that we use to test this are under the kidney capsule. Here are gene therapy transduced mouse islets that have got A20 in them. This is just showing insulin, and these are the controls over here. So you can quite clearly see that an A20 approach, dampening inflammation, can also prevent rejection in these animals. So it makes a very nice logical target. And so he's at a very exciting point now where, with a grant with him through a breakthrough type 1 diabetes, he's created these new vectors that can, adeno-associated viral vectors that can target beta cells that will ultimately end up going into islets and then will come into a clinical trial here with us at the Royal Adelaide to test the function in the next few years or so. So in conclusion, what have I shown you? I've shown you today that chronic pancreatitis produces an intense inflammatory environment which is very detrimental to islet function, and the risk of diabetes requiring insulin up to about 60%, so it's a significant long-term problem. The TPIT for chronic pancreatitis, both nationally as well as internationally, is effective for the right group of patients. I wouldn't want to pretend it's for every patient, but certainly for patients with severe pain, and particularly those with a gene, it's very, very effective. We can stop ameliorate the risk of type 3C diabetes and obviously reduce the cancer risk. We can generate autologous islet organoids, and I think that approach is potentially very promising for the future if we can do that. And obviously this anti-inflammatory gene therapy approach that Shane's been doing, I think, is really quite exciting. And that's supported by breakthrough type 1 diabetes. So if we go and say, well, you know, surgery versus gene therapy, I mean, who wins this particular contest? Well, there's absolutely no doubt that the Mandalorian is clearly the coolest of all of these. So John Chen as the Mandalorian, I think, at the moment defeats Shane Gray as Darth Vader. So if you take away anything, and please tell John I said this, that surgery wins for this, and makes entirely good sense because, of course, as we all know, insulin was actually discovered by a surgeon. We should never forget that. I hope, please take photographs of this. If you have patients with chronic pancreatitis, particularly those with a gene, both in Sydney and here in Adelaide, there are TPIT programs that can offer to help, and there's more from our website over here, and we'd be very happy to see any patients, and we have a national MDT that happens. If you want to join that and just discuss your patients with us, we'd be very happy to do that because it's a really good, one of the best MDTs that I'm actually involved with. Large number of people over the last 20 years have been involved in this work that we've been doing, but I highlight specifically, obviously, John and Shane for their contributions, and wonderful colleagues at the Women's and Children's, Sanjeev Khurana and Richard Cooper, and my entire team over here that do the work. So I'll stop at that point and take any questions.
All right, questions from the floor. Thank you very much for that spectacular presentation, as always, Toby. While you're waiting, I might ask the first question about, you must be doing something right, Toby, because you've got 50% of people independent and not needing to use insulin. Is it because, you know, John Chen and his colleagues are just better at implanting these islet cells, or are you catching the disease at an earlier stage? Would you like to speculate on your brilliant result? I mean, the next is 20%. I think you're far ahead in your class of your own.
Oh, 100%. I think it really is good patient selection. It's having great gastroenterologists, like Nam, people who refer early and are not afraid to say, okay, we know this person's got the gene, we need to get on to this, we don't need to wait. I think the other thing that really helps is great perioperative management. So particularly at Women's and Children's, are really engaged with the endocrinologist. So the pump is on early, and we have tight glycemic control when the islets are most vulnerable post-transplant. That's really wonderful. So if you do those things, you reduce the stress from them. Adding that all together in a really collaborative environment, I think makes a huge difference, and that's what I think actually helps to get these really good results. So yeah, we're very proud of it and pleased that we have done so well, really.
Great talk, Toby.
Thanks, Sam.
I want to compliment exactly your work on the gene therapy. I think actually that have great potential for curing diabetes and possibly reverse actually the chronic pancreatitis. I mean, there's actually other group actually have worked on how to switch on the GLP-1 gene. exactly as a way to combat exactly the diabetes through the GLP-1. What's your plan of actually delivering your gene therapy? I know through the vector locally or systemically that you're going to inject it?
Locally, I think regulation-wise it's really difficult because there hasn't actually been there's no gene therapy trial actually in Australia as yet. So
there will be.
Yes, but this one's coming. So to some extent, educating the TGA about what's required has been very interesting. And in fact, without blowing Shane up too much, he's really helped them understand all of the issues of this. So the beautiful thing about what we're planning, of course, is the islets come out, and then you can deal with the islets. You can use your adeno-associated virus onto the islets, and then so it's very, very much contained. And of course, they're replication-deficient viruses, so they're not likely to cause a problem. And if you're doing it, for example, for the TPIT sort of indication where it's autologous and you're not adding immunosuppression, then the chance of the very remote chance of something going wrong is very, very small. So yes, it is a complicated regulatory pathway that we have to follow. So yes, we're planning to do that rather than giving it systemically, where I think you're going to get a lot of other off-target effects. But who knows? We'll see in the future what they let us do. I guess that's the thing.
Thanks.
Toby, can I ask a question as a surgeon? Fantastic work, and I've been involved with John in a couple of these patients as well. I've referred a couple across. We know pancreatic cancer is a risk with chronic pancreatitis. What sort of tests, if any, we do to rule out the presence of pancreatic cancer in these patients before undertaking the procedure? Because I imagine that would make a huge difference.
That's a great question, and we spend a lot of time debating about that, and we worry very much when we get somebody in their 40s or 50s with this gene, and we think, hang on, could we do something? We might do something absolutely terrible here, because of course you're mushing up the pancreas and potentially giving back malignant cells. So look, I think a lot of it relies on imaging, of course, and clearly the stuff that NAM's been doing and looking at what the pancreas itself actually looks like with endoscopic ultrasound is a really important component of it. And the other thing I think the gastroenterologists can do is clearly aspirate the pancreatic duct fluid and measure CEA and other variety of other potential malignant precursors to exclude that. We haven't been in that situation yet, but I'm certainly aware of at least one case that from the Geneva group where they did a TPIT from somebody in this sort of situation. They've even done it to try to preserve islets in patients with pancreatic cancer and had terrible outcomes where they seeded the liver with essentially with pancreatic cancer mets, and the patients have gone downhill. So it's something we worry a lot about. We do rely on the imaging and rely on the endoscopic ultrasound and the biomarkers to tell us if there's a risk there.
Thanks.
Well, congratulations also on your up-and-coming own centre for harvesting and isolating these islet cells. What improvements in efficiencies and logistics do you foresee with this establishment? And tell me when this is opening.
Yes, when it opens. It opens when I'm confident that we can do as well as Melbourne can. Because you only get one shot at this, and particularly if you're dealing with children, the last thing you want is to have, have the power go out, which occasionally happens in Adelaide, in the middle of your isolation, and you've got your precious sample there, and so really when I'm 100% confident that we are as good or better, but it will make a big difference to our surgeons and our anaesthetists who won't have to get up at 4 o'clock in the morning to do this, to be able to do it during hours. And what they do in Sydney, because they isolate locally, is the patient remains on the table, and they basically come back and they can isolate the islets so quickly that they come back and put them straight in. There are arguments as to whether or not that's necessarily the best thing. To some extent, the distal, the further away isolation does mean that some of the cells that were going to die, that were predestined to die, and so you're losing what you transplant is probably the more viable group of cells. But I'll be happier when we're doing it here and not subject to the local aircraft travelling and the popping in the back of a taxi and all of the other ridiculous logistics that happen when we do this isolation interstate. Thanks, sir. And when it will, well, I hope by the end of the year, but I've probably been saying that for the last 2 years. Anyway, thanks.
Thank you. Thanks, Terry. Great talk. I think our second speaker is not here, unfortunately, so we're going to jump to talk number 3 by Dr. Virginie Gadget, who is a senior microbial ecologist at the Adelaide University and has extensive experience in field studies, research, translation in both environmental and medical studies, as well as health technology assessment. She's currently coordinating a world-first clinical trial project aiming to improve symptoms and health outcomes in patients with unresectable and advanced pancreatic cancer using fecal microbiota transplantation as a co-treatment with chemotherapy. She will present today on the evidence supporting FMT application for pancreatic disease.
Hi, and thank you for inviting me to present. So as you've heard, my background is not medical at all. So if you have medical questions, ask someone else today. But I'm presenting on something a bit different, and I've been asked to do a bit of an update on the literature that's out there on the efficacy of fecal transplant for pancreatico-biliary diseases. So imagine that I had to do a bit of research. As a researcher, you know, it's a bit tricky. How do you skip to the next slide? Here. So, how does the microbiota affect disease or create disease in the body, and particularly in the context of pancreatico-biliary disease? So we know that the gut microbiota is essential to health, and we also have learned through multiple studies how a dysbiosis in the gut microbiota can impair metabolic function and then creates disease down the track. So the way it works is through 3 main pathways. There's an impaired bile acid metabolism. So the liver produces bile acids that are called primary bile acids that have important function in the body, and then they get recycled through transformation into secondary bile acids by the gut microbiota, or good gut bacteria, as we call them. So when there's a dysbiosis, then good gut bacteria can't do their jobs properly. That impacts their recycling, basically. There's also another function that the good gut bacteria have. They produce short-chain fatty acids, which are basically a long word for byproducts of fiber digestion. And those byproducts are really important for gut health, but general health as well. And the main one is butyrate. We know, for example, that butyrate has protective properties against colorectal cancer. All of that also is linked to intestinal permeability. So some of the microbes can produce compounds that can separate the cells in the intestine, and that creates a gateway for microbes to go, and that activates the immune system that then, produces cytokines, and that raises inflammation, which puts more pressure on the liver, for example. And then a third way that they can impact health is by producing biocompounds, or more specifically toxins. So the way we talk to each other is through language and words. Microbes talk to each other with compounds. They just send signals to each other. And some of those are not so good for us, especially toxins. They can disrupt cell communication and the ability of the immune system to recognize tumor formation, etc. And so you get the same thing in various gastrointestinal diseases. Same here with gallbladder disease. Bile acids metabolism is very impacted by microbiota dysbiosis. With the so in cancer, there's also another aspect. We call around the area around the tumor, we call it the microenvironment, tumor microenvironment. And some bacteria are attracted to that microenvironment. It's a bit of a chicken and an egg situation. So were they already there and then produce toxins and then create the tumor? Or are they simply attracted by that cushy little environment that they like and then make it worse? So there's a study that showed, for example, here that in short-term survivors of pancreatic cancer, the tumor microenvironment had less diversity of microbes and that there was an immunosuppression, so the immune system wasn't doing its job properly. While in long-term survivor, the biodiversity of that tumor was more important and the immune system was still activated. There's another role that they have in the cancer sphere. So we know that gut microbiota can affect the efficacy of treatment. So we know that, for example, they can digest some chemotherapy agents, they can affect the results of immunotherapy, and vice versa. Those treatments can have an impact on the diversity and number of microbes that we have in our guts. And so more and more people are looking at microbial interventions as a co-intervention with traditional therapies for cancer. Those are, typical dietary interventions, so diet, antibiotics, quite common. There's actually some trials going on in France, I know, for pancreatic cancer. You can supplement with probiotics, prebiotics. There's a new field with engineered bacteria where they try to change, and as I said, some bacteria are attracted to tumors, so they try to put the drug in the bacteria so that it goes straight to the tumor. So it's a bit more of a targeted approach. You can do phage therapy. So for people who don't know, a phage is a virus that attacks bacteria. So you can sort of target that bacteria by sending a virus that's going to kill it. And then we've got fecal microbiota transplantation, or as I will refer to it as FMT. And so what is the update on what's been done for pancreatico-biliary disease and FMT? So I did a systematic search, and not a lot came back because it's still a new treatment avenue for those sort of diseases. There's a bit more evidence in animal studies and early stages clinical trials. So I'm just presenting what I found recently in my recent search. So there was a bit more on liver disease. This paper was reporting the effect of FMT on alcohol-associated liver disease. And they found that FMT actually improved metabolic function for that disease through the increase of production of short-chain fatty acids. There was a meta-analysis that was done on metabolic-associated fatty liver disease, and what they found is that FMT improved hepatic inflammation, and I can't say that word, steatosis, I don't know how you say it. But there was a lack of BMI improvement, and so they assumed that there was only a localized liver effect and not a systemic metabolic impact like they wanted. They wanted basically the metabolism to be reset after the transplant. And so it goes to think, you might think, okay, so what if you don't modify the diet, then do you lose the benefit of the transplant in the first place? This last one on liver disease was about non-alcoholic fatty liver disease. There was quite a lot of work done there, and I'm just showing the network meta-analysis that was conducted in that paper. So in this paper, they showed that probiotics and symbiotics, so they're just things that you can take alongside your treatment, did show some improvement for that disease, but the benefit of FMT was not guaranteed. And so they did say that it's early days and we need more studies and RCTs to prove it, but so far there's no evidence that FMT is actually helping non-alcoholic fatty liver disease. In terms of gallbladder disease, there was not much. I only found a case report, so basically very weak evidence. And they showed that bacterial cholangitis in that patient improved over 1 year, but then that there was a recurrence. And again, they were asking, okay, so what's the longevity of efficacy of the FMT overall? Do we need to pair it with diet intervention, etc.? I did find that there is one clinical trial currently one RCT done for this, for sclerosing cholangitis, but obviously the results are not out yet, so watch this space. And pancreatic disease is probably what I'm more interested in because of the trial that we're doing, and I'll present the results that we have so far. So FMT did not have a massive impact on solving some of the issues associated with acute pancreatitis. Again, they said that we're only at the beginning and we need more and larger studies to prove the efficacy. For pancreatic cancer, there's only animal studies that are available, and there's 3 clinical trials that I know of currently in the world. One in Texas, they're all phase 1. One in Texas for borderline resectable patients. One in Canada on metastatic disease, and one here in Australia with non-resectable disease, so locally advanced and metastatic. So as I said before, you have evidence, so there is evidence that some of the bacteria through the fecal transplant can improve the efficacy of chemotherapy agents, and one of them is fluorouracil, which is a compound that's used in FOLFIRINOX, which is one of the 2 main agents that we use for pancreatic cancer. So where's the evidence for the trials coming up? So those 3 trials, it comes from this paper. And what they showed, it was in a mice study, and they showed that if you do a fecal transplant from a healthy donor or a long-term survivor of the disease, compared to a short-term survivor, you can significantly shrink the size of the tumor. So there is hope that, it reactivates the immune system and helps the body fight the disease. Why is it important? Well, as we said, or as you know, maybe, pancreatic cancer is no longer a rare cancer. Its incidence has increased dramatically, especially in the under 40. So the cohort between 30 and 40 years old, it has tripled over the last 3 decades, which is not insignificant. So we obtained funding through the MRFF to do this trial. It's a randomized placebo-controlled trial, so it is still a phase 1, so we're looking at efficacy, but we're also looking at whether we can improve mortality in one of the 2 arms. We're recruiting at 3 sites, the Queen Elizabeth Hospital, the Royal Adelaide Hospital, and the Gerard City Pancreatic Cancer Center at Epworth. Through the new GCP rule that was put in place in January, we can recruit from anywhere. So if you have a patient that is eligible, you can get the oncologist to refer them to us, and we can just do the trial appointments at the QEH or the RA. This is our team of experts and investigators. They run across Adelaide University, the BHI, SA Health, Epworth, and Biobank, which is the producer of the capsules. So our population is patients with non-resectable pancreatic cancer. And why is that important? Well, resectable patients are only 20% of the cohort of patients with pancreatic cancer. The 1-year survival is 34%, and the 5-year survival is 14%. Well, if you look at non-resectable patients, so the majority of the cohorts, their 1-year survival falls to 10%, and the 5-year survival is less than 5%. So we're dealing with really sick patients who degrade quite quickly. The intervention is oral fecal transplant, so that's prepared by Biobank here in Adelaide, and we use it as a co-treatment to chemotherapy. So it's just an add-on, basically. We're trying to optimize the chemo, and chemo can be done by gemcitabine or FOLFIRINOX. We do 2 treatments. The first one is pre-chemotherapy, so we try to catch the patients quite quickly and early. We try to restore the immune system's ability, to fight the disease before we start chemo. So we have a loading dose over 3 days. Then the patients get 3 days break and they can start chemotherapy. And the second treatment has the same loading phase over 3 days, and then a maintenance phase about 2 weeks where they take less pills. And that dose is to restore the gut flora after chemotherapy treatment. So what we've done so far with our patients, quite often those chemo agents are really toxic, and they need a bit of a break for a few months. So we tend to do that second dose then, so that they can replenish before they have to go back on treatment. The comparator is a placebo. It's starch, basically. It's inactive. It's prepared by biobanks, so it's double-blinded. I don't know what the patients get, and they don't know what they're getting as well. Our primary outcomes, because it is a phase 1, are safety outcomes, so adverse events, serious adverse events, and mortality. And we're measuring those continuously, but we also measure all measure outcomes at baseline, 3, 6, and 12 months. Secondary main outcomes, so we've got visceral pain, so we measure that through the Pagesim scale, length of survival, quality of life using the EQ-5D-5L scale, treatment efficacy, so of clinical relevance, so we're looking at changes in tumor size and numbers, as well as blood CA99, knowing that biomarker doesn't work as efficiently sometimes with certain blood types. So we found that we had patients that showed no elevation of CA99 with a really advanced pancreatic cancer. And then we're looking at changes in fecal microbiota diversity and activity. So the role of that part is to look at gut function restoration, but also to identify the microbes that might be a bit better at helping. So not every donor is going to be equal. We know that some will be better than others, and also analyze what in the microbiota of those patients before treatment could be the root cause of their disease. So what we would like to see is a decrease in visceral pain and discomfort, a decrease in GI symptoms, hopefully, between the two arms, improvement in patient gut function and quality of life, and more importantly, we want to improve their treatment. So we hope that we can help the chemotherapy. So far, we've had 30 participant screens. So we started after a very long and painful fight with governance. We started in February 2025. We have consented 20 patients. So we had about 3 screen fails, I think, and they had to do with use of antibiotics around the consent time. Most people who did not enter the trial wanted the poo capsules, but didn't want to do the chemo. And we couldn't do that, obviously, ethically, that's not approved. In terms of follow-up completion, so those numbers reflect people who, from the start of chemotherapy, would have to meet the 3 months mark or the 6 months mark. So as you know, those patients are really sick, and we have lost patients, they tend to die quite quickly. So we've had 65% finishing their 3 months follow-up, 42% at 6 months, and then 67% at 12 months. Knowing that some of those were discontinued because of disease progression, but are still alive. So not everyone's died quite yet. There's still hope. We had no FMT-related serious adverse events, which is good, and only 7 AEs that were related to IP, which were all mild or moderate, usually increase in burping, mild diarrhea, that sort of thing. The recruitment will continue until the end of this year, so if you have any patients, again, please refer them to us. The follow-up will continue until the end of next year, because we have to do a 12-month follow-up. And we anticipate to publish at least the interim data in the second semester of next year. And that's it for me, if you have any questions.
Thank you. Thank you, Virginie. Excellent talk and great work going on. Clearly, a group of patients who have pretty poor prognosis at the moment. Do you think the trial is going to show any improved survival, or is that something that we are going to be looking at some stage?
I think it's a bit early, and I think so this is my first clinical trial, by the way, so steep learning curve. I think the model in which we applied it might have been a bit detrimental, and so well and good to say that, after the fact. But we get a lot, so those patients are really sick. They get infections, so they get antibiotics. And so I was just discussing with our colleagues from Epworth, we're thinking, well, maybe the next step, because we are seeing patients during the 12-month mark that were really, really past, the resectable zone. And I'm blinded, so I don't know. Maybe they're on placebo and they're just living their best life. But I think if we can potentially, instead of having those 2 big doses, just monitor, just give that in that week off that they have in the cycle, so that you replenish and help the chemotherapy, maybe that would be more beneficial. So it's just little things like that we will learn once we unblind patients, and that we can, but I don't know, we're still hoping, it's hard. Holding their hands until the end, it's not been easy, but you have to hope that we're helping.
Nam?
Thank you for a great talk. Again, FMTs is actually so popular that we actually explore in all area. But if you look at the rationale, I have 3 questions. Mm-hmm. First, actually, have you considered checking the 5FU level?
The what, sorry?
Have you actually considered, or have the group considered checking the 5FU level, the fluorouracil, the agent that you actually hypothesized that the FMT actually will improve the efficacy and actually possible the level for the effectiveness of the treatment. That's number 1. Number 2 is have you looked at the biodiversity of the patient actually before we actually start the trial?
Yes.
Because actually I think again we based on these things, and we don't know what happened with the biodiversity. I think the high diversity associated with better outcome. Am I correct? And also it's also their diet as well. So have we looked and controlled their diet as well?
At what, sorry?
The diet.
The diet.
Yes.
So one of the questions, the 3 questions, so I tried to answer them, remember. I'll start with the last one. So the diet, because we don't have a dietitian basically on the trial, so the only way we can monitor it is to see if their diet changes at baseline, between baseline and along the trial. So at each of the appointments, we have a diet-based questionnaire. And we're looking specifically at intake of fiber that are beneficial to the gut microbiome. As I said, it's a phase 1. So for us, it's just getting that initial data to understand our cohort. One thing I can say, so we have also habits, so smoking, drinking, that sort of things that are taken into consideration. All our patients have been smokers, nearly all of them. And then most of them are drinkers as well. So, it gives you a bit of self-reflection. You're like, oh, maybe I won't have that one this weekend. So we monitor what we can about the diet and their daily habits. Second question was about, do we monitor the microbiome? So because it's quite expensive and we have to outsource it, we can't really do it patient to patient before we start treatment. And again, we're trying to capture them before they start chemotherapy. Sometimes I just have a day to manage the patient before we get them on the trial. So technically, we don't have the capacity to do that quite yet, but we are monitoring them. So we're getting a stool samples at baseline, and then we compare after treatment to see if the treatment took as well. So Biobank will provide us with the meta-analysis of their patient stools, their donor stools, sorry, so we can see whether there's been retention or not. And that could help us as well identify which microbes are important, if they're efficient, but also maybe which patient could benefit most from a fecal transplant. So it goes both ways. And in terms of the dosage, I'm not sure I understood the question. So we've got patients with different dosage and different chemotherapies. So my understanding, again, I'm not a clinician, Abraxane gem is recommended for metastatic cancer. And that's the majority of patients that we have. There's also evidence that gemcitabine is digested by some of the gut microbiome. microbes. So we'll see what happens down the track, but am I answering your question, or? Yes, okay. So we're just monitoring who was on who, and we're trying to have that balance between the two groups. Yeah. Yes.
Great talk. I'm Steve from Sydney. I was just wondering, what engagement did you have with patients who had disease in terms of designing the study and reporting back to them?
So I actually wrote that grant with a friend of mine whose father died of the disease. And so she's been instrumental in designing the environment of the trial as well. So she said that, so she told me all about her dad's journey and what she would have liked, basically, through that journey. We also have a long-term survivor who's helping us on the trial. 11 or 12 years after diagnosis, he's done really well, and he's very heavily engaged in the research community in Adelaide. So he's working with everyone, basically. He's working with every group that I know are working on pancreatic cancer. One thing that we implemented from that consultation is adding Creon as an automatic prescription. So Creon replaced the enzyme in the pancreas, and we found that all our patients actually feel a lot better already once they start that. So I think, if anything, we're getting data. If patients on the placebo do better than the national, maybe it's because they're having Creon, or maybe it's because they're on a clinical trial and they get monitored a little bit closely, more closely. So, yeah, that's what we've done. I think what's interesting with FMT as well, it's more and more difficult to get good donors, especially since COVID, because COVID gets shared in stool, and Biobank in particular, they're looking at obtaining that data to make a probiotic more than a fecal transplant. So extracting the microbes are important so that we have a more targeted treatment. But also, when I was talking about the longevity of the effect of the treatment, how long does that last? There's no answer for that. All the studies are short-term, and I think we might find that it doesn't last long unless you do a diet change, unless you look at the genetic behind, the innate genetic of the patient. Do they have something that doesn't, a genetic mutation that doesn't transform something that's essential to gut bacteria, and then no matter what you're going to do, it will revert back. So I think we're still in the infancy of the science behind it, but there are still encouragements for the application of FMT.
Did we have any other questions? No. So thank you for our speakers for that session. It, I guess, has shown us that there is more to pancreatico-biliary disease than can be just managed with EUS and ERCP, as much as it breaks my heart to admit that. So I think we're coming to the end of the sort of clinical or the lecture-based talks for today. So I'd like to invite Nam back up to this stage for the formal conclusion, and then we'll head on to lunch and then the hands-on stations after that.
Great. Thanks, Millen, and thanks both speaker Toby and Virginie for excellent talks. I'm sure that we again learned a lot today from the lecture and overall over the last day and a half. So I would like to thank everyone that have contributed our international, national, and local speaker, our delegate. For some of you who will attend the hands-on workshop, please stay. The workshop will be commenced at 1:30 at level 5, so we will direct you. But otherwise, I would like to officially conclude the symposium, and thank you everyone. Have safe travel for those who travel interstate, and the rest of you hopefully have a good weekend. Thank you.
Last year, a great meeting this year, and Nam's really been the driver behind this. So a round of applause for Nam.